Welcome and thank you for joining us today. My name is Rohit Mehra. I'm a GU pathologist at the University of Michigan. I'm a member and also chair of the GUPS Education Committee. It is my distinct privilege today to open this inaugural session of the GUPS-IAP Arab Division Joint Educational Series, which aims to highlight evolving practice concepts in genitourinary pathology. Today, we are honored to launch this collaborative initiative between the Genitourinary Pathology Society and the International Academy of Pathology Arab Division. And this collaboration has been envisioned by Dr. Maggie Glutzi, Dr. Zathri, and Dr. Kassouf, who are all present on this session and whom I will be introducing also shortly. Like you may know, GUPS was established with a clear and enduring mission to advance patient care through excellence in education, research, and implementation of best practices in genitourinary oncology. Today's series reflects this mission while extending it through partnerships with an organization that is equally committed to elevating surgical pathology practices across diverse areas on the planet. The IAP Arab Division, one of the active regional divisions of the International Academy of Pathology, has a distinguished record of promoting high-quality pathology education throughout their region and beyond. Through their conferences, workshops, and digital platforms, this division has played a central role in supporting professional development and fostering international collaboration. Their dedication to advancing diagnostic standards and strengthening the pathology community makes this joint educational effort very unique, timely, and I also personally feel very meaningful. To begin our proceedings today, I'm requesting our GUPS President, Dr. Christina Maggie Glutzi, to inaugurate our GUPS IAP Arab Division Joint Educational Series and say a few words about this unique collaborative initiative. I'm certain you know that Dr. Maggie Glutzi is a professor and chair of the Department of Pathology at the University of Alabama at Birmingham. She is the current president of our Genitourinary Pathology Society, and she's also president-elect of the United States and Canadian Academy of Pathology. So all of us are very excited to interact with her at the coming USCAP meeting in San Antonio. Christina is a founder member of GUPS and also has served on the USCAP board of directors. Over to you, Christina.
Thank you, Rohit, and thank you, everyone. Hello, everyone. Welcome to our first GUPS IAP Joint Education Series. I am actually very excited about this joint educational activity that was developed in coordination between the Genitourinary Pathology Society and the Arab School of Pathology of the Arab Division of the International Academy of Pathology. This effort actually reflects the GUPS' ongoing commitment to building meaningful global partnership with leading professional organizations. And through such collaboration, we aim to advance excellence in education, strengthen current standards of practice, and also proactively address emerging challenges in the rapid evolving field of GU pathology. Together, these shared efforts amplify actually our collective impact and foster a truly international exchange of knowledge and expertise. I would like to take a minute to thank Dr. Zathari and Dr. Kassouf for their collaboration, and also Dr. Reza Alek-Abandon for facilitating actually this partnership. He was actually involved in fostering these original meetings with the three of us. I'd like also to express my deepest gratitude to the GUPS Educational Committee for organizing this amazing first joint educational series, to the moderator, Dr. Brimo, Memon, and Dr. Mera, and also last but not least, of course, to our speakers, Dr. Lal, Dr. Matoso, Dr. Jia, and Lotan for their involvement and for their engagement. Thank you, everyone, for joining us for this exciting educational journey. Thank you, Rohit.
Thank you, Christina. And again, I absolutely agree. I think thanks a bunch to Reza also for facilitating this collaboration. Thank you, Christina. Next, I would like to invite Dr. Ghazi Zatari to say a few words about this joint educational series event which we are hosting today. Like you may know, Dr. Zatari is chair of the Department of Pathology and Lab Medicine at the American University of Beirut in Lebanon. He's the vice president for Asia for the International Academy of Pathology. He's secretary of the Arab division of IAP, as well as president of the Arab Board of Pathology. He's so distinguished and so qualified, and I think holds a high chair in the WHO as well. And I think it was very interesting for me to actually learn about him that he's also the current chair of WHO's study group on tobacco product regulation, which, like you know, is such an important initiative all over the world. Thank you, Ghazi, and over to you, Ghazi.
Hi, good day to all of you. It's a great pleasure. I think this is a historic landmark for us. I think this activity exemplifies what the International Academy of Pathology and GUPS stand for, in the sense of fostering a exchange in education and knowledge. And we're very thankful for this initiative. And what even makes me more excited, the fact that we're calling it the first, with the idea there are going to be more to follow. And I think here I have to acknowledge this initiative. I think Riza's name was mentioned, but at the same time, I'd like to thank Christina and Rohit for picking this up. They were highly enthusiastic about putting it together in order to establish this global partnership that I'm hoping will last. And I think while today we're thinking about webinar, in our early discussions, we also considered other means of collaboration, and hopefully time will tell in which way we can build on this relationship to something to advance this collaboration. And I'm very thankful for the outstanding speakers that we have been able to recruit to share with us their knowledge and expertise and sharing it with the world of pathology globally. I think today the world is getting smaller, and exchanges like this will only build up and help in building better practice of pathology worldwide. So thank you all. Thanks for this wonderful opportunity, and for the moderators, and I will turn it over back to you, Rohit.
Thank you, Ghazi, and thanks for those amazing and so encouraging and supportive comments. And all of us at GUPS are looking forward to a series of collaborations which are getting initiated today. So thank you, Ghazi. Finally, next, I would like to invite Dr. Hala Kassouf to share her thoughts about this event and this unique collaboration. Like everyone might know here, Dr. Hala is Professor of Surgical Pathology at Department of Pathology and Lab Medicine at the American University of Beirut itself. Hala is chair of the Arab British and the Arab Schools of Pathology and the president of the Lebanese Society of Pathology. She is also currently the president-elect for the International Academy of Pathology Arab Division. Over to you, Hala, please.
Thank you, Rohit. Good day, colleagues and participants. It's both an honor and a pleasure to welcome you to this collaborative webinar by the GUPS and the International Academy of Pathology, the Arab Division. I would like to thank Dr. Ghazi Zatari, Secretary of the IAP, and Dr. Christina Maggi Galluzzi, President of the GUPS, for the initiation and follow-up of the project. I'm grateful to Dr. Rohit Mehra, Chair of the Education Committee at the GUPS, and Dr. Maysa Al-Husseini, Secretary of the International Academy of Pathology, the Arab Division, for the continuous help and support. This event exemplifies our shared commitment to advancing knowledge and fostering collaboration in the field of pathology, particularly this evening or this day within the genitourinary domain. Our discussions today will not only enhance our understanding, but also strengthen the ties that bind us as a global community. I urge everyone to engage actively, ask questions, and share insights. Together, we can make a difference and improve outcomes for our patients. Thank you for being here, and I wish you a fruitful and enlightening session with our distinguished speakers. Have a nice evening.
Thank you so much, Hala. I think there are like such important comments you made, and I think also also reinforces why all of us are here today, to learn and to essentially to work more and more and help benefit our patients. I believe that is the main reason all of us are here today. Thank you, Hala.
Thank you.
Finally, we come to our main session proceedings now, which I think, like Christina, Ghazi, and Hala have mentioned, brings together an exceptional group of experts who will address important and evolving topics in genitourinary oncology. Our session is titled Decoding Malignancies of the Genitourinary Tract, Morphology and Molecular Pathology Meet Clinical Practice. We are privileged to have 4 outstanding GU colleagues speak at today's event, Dr. Priti Lal, Dr. Andres Matoso, Dr. Liwei Jia, and Dr. Tamara Lotan. Their collective expertise represents a breadth of experiences that will undoubtedly enrich our understanding of current diagnostic challenges and emerging developments in the field. Not only these are prolific speakers, I think our GU colleagues or experts also have a great trajectory of publishing cutting-edge literature, which I personally follow all the time on PubMed. Today's session is being co-moderated by Dr. Fadi Brimo and Dr. Santosh Menon, who are both members of our GUPS Education Committee. And Fadi, Santosh, and I represent our entire GUPS Education Committee, and this actually agenda has been developed in collaboration and in consideration with all our members of GUPS Education Committee. So I would like to thank all personnel enrolled in our GUPS Education Committee. Thank you all. Dr. Brimo is an associate professor of pathology at McGill University and the pathology chief at the McGill University Health Center Glen site. Dr. Brimo is the recipient of the Canadian Association of Pathology Junior Scientist Award and the chair of the Canadian Society of Cytopathology. Dr. Menon is professor of pathology and urology at Tata Memorial Hospital in Mumbai, India. Dr. Menon has served as an editorial board member on the 5th series WHO Blue Book on male GU tumors and is also the secretary of the Society of GU Pathologists of India. A couple of housekeeping items. As we listen to the presentations from our 4 speakers, we invite all attendees to please submit your questions throughout the session during the Zoom Q&A features. Our speakers will address these questions at the conclusion of the 4 presentations. It is now my pleasure to turn the program over to Dr. Fadi Brimo, who will introduce our first speaker, Dr. Priti Lal. Over to you, Fadi.
Thank you, Rohit, and a big thank you for all of you joining this special session from around the world. It is my pleasure to introduce Dr. Priti Lal, who will deliver our first lecture. Dr. Lal is a professor of pathology and laboratory medicine at the University of Pennsylvania and the director of urologic pathology program. After graduating from Maulana Azad Medical College in New Delhi, India, Dr. Lal completed a Fogati Fellowship at NIA, NIH, and residency in pathology at UMDNJ, New Jersey. She completed fellowships in oncology pathology and molecular pathology at Memorial Sloan Kettering Cancer Center, and subsequently joined the faculty at the University of Pennsylvania. In addition to her busy clinical practice and teaching portfolio, she is a co-principal investigator and a co-investigator on several important NIH and DoD grants. Dr. Lal has developed an extensive, well-annotated digital registry for primary and metastatic prostate and bladder cancer. She is an author on more than 100 peer-reviewed research papers and has contributed towards several book chapters. Dr. Lal was elected treasurer of GUPS and serves on several committees at USCAP and other pathology societies. Dr. Lal enjoys mentoring budding pathologists and researchers. The title of Dr. Lal's lecture is Clinically Relevant Pathology Reporting of Prostate Cancer and Its Value in Multidisciplinary Team Management. Dr. Lal, the floor is yours.
Sorry, Priti, you are muted, please.
You're muted.
Can
Can you hear me okay?
Yes, please. Please go ahead.
Yes, we can hear you.
Hello, everyone. I'm excited to be here and welcome. As the title of my talk indicates, today I'll be talking about and highlighting how accurate and comprehensive reporting of prostate cancer influences the decision-making and management of prostate cancer. So as you can imagine, this is a very large topic, and to be able to tackle this vast topic in 25 minutes, I have arranged my talk to give you a little bit of snapshot of prostate cancer so we can understand the scope of the problem, a little bit about Gleason score and grading in the context of clinical management algorithms, to put in focus how our pathology reports influence patient choice for management and clinical direction for subsequent treatment. In order to do this, I've also divided the lecture into by taking each Gleason pattern, and because of the limited time, shortly going over the differential diagnoses and important salient features to keep in mind as you allot different Gleason patterns to your patients' material. A lot has happened in the field of intraductal carcinoma of the prostate. I will spend a lot of time focusing on this, clarifying what the updates are, but also briefly touch on other lesions that affect prostate ducts. And the last slide, if I have time, I wanted to bring to attention how each of the modalities of diagnosis and management are a treasure trove of biomarkers that can, in the future, be leveraged via AI. So here we go. The first slide here shows the global extent of prostate cancer. The maps here are global age standardized incidence and mortality of prostate cancer. What we see here is that all regions of high incidence do not have a high mortality rate. And what it tells us is that we are picking a lot of indolent cancer. Now, if you take a closer look at the bar chart here, you see how varied the incidence is. It varies from as much as 50-fold. However, even in the high incidence regions, the mortality is on an average very stable, except for pockets in the world where there is more aggressive cancer, like the Caribbean and Sub-Saharan Africa. Prostate cancer is the fourth most common cancer in world over. Within United States, 1 in every 8 men will be diagnosed with prostate cancer in their lifetime. The incidence in the United States per 10,000 population is 114.7, whereas the mortality is 18.7. So now let's take a look at how this disease is distributed by stage, and then we'll also put it in the context of grade. So at first time diagnosis, 80% of the patients have organ-confined disease process that is confined within the prostate. And these patients do extremely well with 90 to 90% 5-year overall survival rates. Even with regional lymph node metastasis, the outcome, which constitutes about 15% of diagnosis at first time, the outcome remains at 60 to 80%. And at only with distant metastasis, it falls drastically to 30 to 40% for 5-year survival. Now, within each stage, Gleason score plays a very important role in risk stratification, especially when we look at 10 to 20-year outcomes of survival. And as you can see, Gleason score 6, which is primarily pattern 3, which is purely pattern 3, has nearly 100% survival 5 years, but it is not 100% subsequently when you follow patients at 10 and 20 years. And similarly, other Gleason scores influence how we stratify for risk within each stage. Now, risk factors of prostate cancer, as we discussed, there are certain pockets in the world that have higher, men have higher risk of developing prostate cancer. Age is the most important predictor of prostate cancer in the sense that it is a disease of older age population, or and higher grade cancer, this is from Decipher statistics, tends to have a higher percentage of higher grade group. Family history plays an extremely important role. Any cancer in the family increases the risk of prostate cancer, but specifically history of prostate cancer increases the risk more so, and the statistics are shown below. Genetics plays a very important role. BRCA2 and BRCA1 in that order are highly associated with prostate cancer, but one has to remember that there are other genetic polymorphisms that play a big role in increased incidence of prostate cancer. The most common tool used in identifying and screening for prostate cancer is the prostate-specific antigen, or the PSA. As the name suggests, this is prostate-specific, not prostate cancer-specific. Therefore, even benign conditions like UTI, etc., or anything that perturbs the epithelium may lead to increase in PSA value. Therefore, there is no definite cutoff at the lower end where a man can be told that he has no risk of harboring prostate cancer, or a higher than PSA 10 of 10 nanogram per ml, where they can be definitively told that they do have prostate cancer, because even then the chance is 1 in 2 or 50%. So over the years, it became apparent that over identification of clinically insignificant prostate cancer was leading to overdiagnosis and overtreatment. With advancing technology, multiparametric MRI quickly became an important tool, and combined with PSA screening, PSA dynamics, multiparametric MRI analysis, we are now progressing towards a more definitive or more focused diagnosis of clinically significant prostate cancer. So just like pathologists divide prostate cancer into 5 groups, radiologists divide prostate images into 5 groups, with the lowest score being 1 on a scale of 1 to 5, being the highest. And going from unlikely to be clinically significant prostate cancer to highly likely to be clinically significant prostate cancer. What does that do for a patient? So in the hands of an expert radiologist, the sensitivity and specificity of an MRI read can reach up to 80% in identifying clinically significant prostate cancer and separating it from clinically insignificant prostate cancer. That helps triage patients who would actually need treatment and biopsy, therefore, and therefore reduces the chances of overtreatment. Furthermore, MRI analysis also helps in planning surgery better by giving an extensive idea about how close the cancer is to the neurovascular bundle, whether there is extraprostatic or extension or not, and so on and so forth. And MRI finds its place throughout the management of prostate cancer. Now, let's focus on biopsy because that's where we interact the first time with the patient. So in our practice, depending on whether a patient had an MRI or not, we get two kinds of biopsies. One is the traditional systematic biopsy, which maps the prostate into quadrants and fossa and locations within each half and each quadrant. And then there are biopsies that have multiple cores from the target as delineated by MRI, in addition to the systematic biopsy process. Rarely, when they are very sure this is going to be cancer and the lesion is very apparent, there could be just some focused biopsies. Now, this is a very famous chart that we all know about, and it is the journey of Gleason's score over the decades to clarify, focus, and really define the various risk categories of Gleason pattern. So as we apply Gleason pattern to needle biopsies, TURP, and prostatectomy, Gleason patterns 1 and 2 are never diagnosed on needle biopsies. Gleason pattern 1 and 2 exist on theory, but I personally have never diagnosed them on a prostatectomy or TURP. The Gleason score, therefore, majority of the time, whether it's should start at Gleason pattern 3. Now, with the 2014 definition, pattern 3 only has well-formed glands that respect each other's boundary. Pattern 4 contains all other patterns of poorly formed glands, cribriform pattern, whether they are irregular pattern of cribriform or regular pattern of cribriform and fused glands. And then pattern 5, again, is a heterogeneous group. Taking the most abundant and the highest score, then we pattern, we reduce a score. The score, it then finds its way into the grade groups as shown here. These grade groups play an important role on how a urologist will look at and advise their patient. So taking the PSA values, the clinical stage, and the Gleason score that you assigned, different algorithms or nomograms stratify patients in two different ways, either just 3-tiered stratification or further stratification of low risk and high risk into very low risk and very high risk groups. Taking that information, finally, there is either further workup, radiologic workup, or treatment planning. radiologic workup to look for lymph node metastasis, etc., or treatment planning according to these risk stratified patients. So what are the steps that we as pathologists should make sure that find their way into our practice and thinking algorithms? So remember, Gleason score is given at a core level only if your urologist submits scores in a jar or from a specific location as a single core. When there are multiple cores from a specific location, an aggregated score is given to this. A side note on this, in our practice, if we get such a large number of cores in a cup, then we separate them into 2 blocks, putting at the most 3 cores per block for the ease of reading, as well as embedding and cutting, which is a very important part of a well-made H&E. So the components that should find their way in your report, irrespective of the grade group, are Gleason score, grade groups, linear length or percentage of parenchyma involvement. You have to specify how many total cores you got and how many were positive, and also make sure that you designate whether there is perineural invasion, and look out for extraprostatic fat sampling and whether it's involved or not. Additionally, know the context in which your biopsy is being done, whether this is a first-time biopsy, post-radiation therapy biopsy. That will help you with making accurate diagnosis and also prevent you from going down the wrong diagnosis. Remember, Gleason score is an architectural scoring system. Therefore, 4x or low power is critical for you to understand your lesion. Knowing a patient's normal within that core obviously will help you much more than the high magnification that you might be tempted to go to right away. The high magnification should only be used to confirm certain cytologic details. Immunohistochemistry should not be used for grading. However, it should be used as a supportive ancillary technique. So as we said, Gleason score is an architectural scoring system. So majority of the cancers will have acinar pattern. And in the subsequent slides, I'll take each pattern, put it in the context of how it influences the grade group and therefore treatment algorithms. Ductal patterns are less common. However, I'll spend a lot of time on intraductal. I will not talk about high-grade PIN. We'll talk about a little bit of ductal and intraductal, and just a slide, if I have time, to go over AIP. All right, so here is a slide showing pattern 3. These are normal glands of this particular patient, which show very open architecture. And even at low power, one can see that there is double lining of these glands with the basal and the epithelial cells. And in between is what we call the infiltrative nature of prostate cancer. Here again, you can see some glands that are very open, and the stroma in between them is easily visible at low power, whereas others tend to cluster a little bit more tightly and at low power may appear to be effusing. However, at high power, you can double check and make sure, even if a small amount of stroma separates the 2 glands, that's still a pattern 3. Now, there are some cancers that mimic benign entities. So, for example, atrophic variant of prostatic adenocarcinoma. This is extremely rare, but if you have it in mind, you will pay attention to the architecture, detail, and growth patterns, and will be able to raise the differential diagnosis. Then, as even within this case, you can see prostate cancer that appears to have open lumen very similar to the adjacent benign glands. And this is pseudohyperplastic prostatic adenocarcinoma. And then the famous foamy cell variant of prostate cancer, where the cytologic criteria don't hold up, which is prominent nucleoli and large nuclei. When you get a large prostate sampling of prostate cancer on your needle biopsy, teach yourself to look at the softer signs are of prostate cancer, for example, amphiphilic cytoplasm, more eosinophilic, solid-looking cytoplasm in the cancer, intraluminal blue mucin, crystalloids, mitosis, and all these, when you keep observing in a larger lesion, you'll be able to apply them when there are smaller, more challenging lesions. When you see definitive perineural invasion, even a small lesion can be called cancer. But if that's the only lesion in the case, it's better not to grade it. Finding a cribriform pattern of mucinous fibroplasia is again a definitive sign of cancer. These two entities, extensive mucinous pattern in the background, does not automatically make a prostate cancer pattern 4. You have to mentally subtract the background mucin and apply the grading system to the glands that you see, and the same holds true to the mucinous to this lesion here. The most difference in inter and intra-observer observation is in poorly formed glands. So here on the right side, I have a false colored AI-enhanced H&E from a deparaffinized tissue from prostate cancer. And what this image shows is that prostate cancer is not like rings or Cheerios. Rather, it is like blunted tubules that traverse the 3D environment in a haphazard manner. Therefore, when we cut through this, the plane of cut will determine how this tumor looks on our slide. It is therefore important for us as pathologists to look at all levels to get the real context of a lesion before upgrading from grade group 1 to grade group 2. Just like there were some prostate cancer subtypes that were mimicking benign patterns, there are many benign patterns that mimic prostate cancer. I don't have enough time to go over it, but I did bring this to you. I did want to bring this to your attention. There are multiple papers out there that have tried to divide them in many different ways for you to understand. The most common ones are in our practice is atrophy, basal cell hyperplasia, post-atrophic hyperplasia, adenosis, and depending on the way the biopsy was taken, Cooper's glands, or even seminal vesicles and ejaculatory ducts. So just even keeping these entities in mind and differential in mind is half the battle won. So once you have...
Sorry to interrupt. Just a gentle reminder, you have 12 minutes left.
Yeah, once you have assigned grade group 1, the patient will then go into active surveillance if the protocol determines as such, and your report will help them finesse the management subsequently. This slide I put here just to make sure that each and every component of your report finds its way in some kind of decision making, and each part of it therefore becomes really important. So now let's go to pattern 4. Pattern 4 can be divided into primarily cribriform pattern and non-cribriform pattern, which is fused glands and poorly formed glands. Cribriform pattern has an entire spectrum and is associated with extraprostatic extension, positive surgical margin, distant metastasis on prostatectomy, and in the long run, increased biochemical recurrence, and also associated with increased prostate-specific mortality. Again, keep all the points that we previously pointed out before you apply a Gleason score, especially in cases like this, where there's lots of mucinous background. Now, Gleason 4 can be seen in intermediate to high-risk prostate cancer. We'll focus on intermediate-risk prostate cancer. So when reporting intermediate-risk prostate cancer, you have two groups. Prognostic group 2, which is less than 50% pattern 4, and prognostic group 3, which is more than 50% pattern 4. And there is overlapping decision-making and prognosis between the two, depending on what is the extent of adverse pathologic characteristics that a particular patient with or two patients with similar grade group have. So grade group 1 is the most commonly associated with active surveillance. However, more and more, if patient doesn't have any of the adverse features like IDCP, AIP, cribriform pattern 4, with a limited amount of pattern 4, these patients, and of course in the clinical context, these patients may actually be candidates for active surveillance. There is also definitive implications to how much radiotherapy and ADT will be planned depending on the patterns. Now let's switch gears to ductal lesions. As I indicated before, we will not be discussing high-grade PIN. Let's start with intraductal prostatic adenocarcinoma. The definition of intraductal carcinoma of the prostate is by WHO is a lumen-spanning proliferation of cytologically atypical prostatic secretory cells within distended pre-existing ducts and acini, which displays at least partial preservation of basal cells. The architecture can be varied from dense, solid, cribriform to loose, and the cytology is variable with extensive nuclear pleomorphism to minimal nuclear pleomorphism. The behavior is frequently associated with high-grade cancer, prostate cancer, and is an indicator of poor prognosis. So with the current GUPS-IAP consensus, the diagnostic criteria to be used for diagnosis of intraductal carcinoma of prostate is the updated Guo-Epstein criteria. In this, we do not anymore require the nuclear size to be more than 6 times the normal, and there we can also diagnose IDCP based on extreme nuclear pleomorphism after you exclude possible radiation therapy or other normal structures like seminal vesicles. So I'm going to skip into this slide because the paper goes into great details, finer details. But what I want you to take away from the paper that is published in Histopathology is how to grade intraductal carcinoma and how to integrate it in the Gleason score. So if you identify IDCP without any invasive prostate cancer in the background, it is recommended that such lesions should not be assigned a Gleason pattern. So your report will just say prostatic intraductal carcinoma, C note, and this would help the clinicians to either further workup with additional biopsy or correlate better with the radiologic findings. And then there is IDCP in the presence of invasive cancer. When you see IDCP in presence of invasive cancer, you have to give it a pattern 4, except when it has comedo kind of necrosis, then you have to give it a pattern 5. So, again, the rules will apply the most common pattern and the highest pattern. But now there will be more, if you have been following the GUPS outline from before, guidelines from before, you will be assigning IDCP pattern 4 as well. So what are the implications of IDCP? So one thing I wanted to point out is this, despite including it in grade group, you have to continue to identify patients who carry IDCP and those who don't. And there are some reasons for it. The IDCP carries worse prognosis. It predicts resistance to certain therapies. And NCCN guidelines still has recommendations for genetic workup of these patients. So now let's change to ductal carcinoma of the prostate. Again, the definition, starting with the definition, ductal carcinoma of the prostate is composed of papillary structures and/or complex and cribriform glands lined by tall, columnar, pseudostratified cells. This is where this really helps us to clarify our diagnosis. So here is an example of stratification of nuclei. Here is a low power view that shows you fibrovascular cores making a true papillary proliferation. And even when there is cribriform appearing regions, the cribriform areas are slit-like and there is slight stratification to the nuclei. So here is a side-by-side comparison of ductal and intraductal. Ductal will have stratification. These intraductal will have cuboidal cells, and so on and so forth. So make sure that you understand how to grade these lesions. Ductal carcinoma has always been graded as pattern 4 without when there is no comedonecrosis, and with comedonecrosis as pattern 5. These are extremely rare entities as pure entities, but a majority of the time you'll see them in the context of invasion. Reiterating the fact that IDCP in its pure form should not be assigned a grade, and IDCP in the presence of invasive cancer is assigned a grade according to presence or absence of comedonecrosis. Pattern 5 is a whole range of different patterns, including comedonecrosis, as we already saw in IDCP and ductal carcinoma, as well as invasive cribriform. It also is composed of single cells, cords of cells, etc., which is the traditional way of looking at it. Now, one of the things that I wanted to point out is there's a difference in how we use pattern 5 in prostatectomy versus needle biopsy. In needle biopsy, there is no tertiary pattern, whereas in prostate, you will have tertiary pattern, and the way to report it is to put the score, put the grade group, and reiterate if there is a tertiary pattern. When the pattern 5 is less than 5% of all patterns. Now, according to the grade groups assigned, the risk stratification will be either high risk or very high risk, and accordingly, treatment plans will vary. So now that brings us to the last slide here. And this is atypical intraductal proliferation. It is a diagnostic gray zone that saddles the gray zone between high-grade PIN and IDCP. So the implications of high-grade PIN are very different from AIP. So the way to look at AIP, it is more, the lesion appears more atypical than you are comfortable calling high-grade PIN, but does not reach the threshold for it to be called IDCP. So by making this diagnosis, you help the clinical team to follow this patient more closely, either with needle biopsy, and if they haven't gotten an MRI, then get a more focused biopsy. So with that, I hope I have been able to demonstrate the fact how our Gleason scoring process plays an important role in risk stratification of prostate cancer. From identifying patients who will do excellent, who will have excellent outcomes at low risk or very low risk, and therefore can keep their prostate and active lives and stay on active surveillance protocols, whereas those that definitely need a more aggressive treatment. So the last slide that I have here is just a summary of all the tools that are more commonly used in diagnosis and management of prostate cancer. So PSA is, right now, blood work in terms of PSA is the minimum that we use. However, blood is a snapshot of and enables and a carrier of multiple biomarkers. PSA dynamics, along with leveraging biomarkers in the future, may play a very important role in further stratifying patients by risk categories. Same with MRI images and prostate needle and prostatectomy images. There is a log-fold more information available if we leverage AI tools and digital pathology that's available to us for analysis that is not visible to the eye. The way we stratify the PIRADS, the way we stratify prostate cancer. So in the future, perhaps the combined use of AI algorithms, large language algorithms with clinical collation of clinical data, image-based algorithms that can glean subtle changes that make a difference in outcome, together will inform risk stratification much better. So with that, I hope I have been able to demonstrate what my title wanted to, which is clinically relevant pathology reporting of prostate cancer and its value in multidisciplinary team management. I thank you very much for your attention, and I will take any questions.
Thank you, Dr. Lal, for that very, very enlightening presentation of yours. There are some questions which we'll be taking after all the 4 talks are done. I would also like to remind all the attendees that they should put their Q&As in the Q&A section, and all questions will be taken at the end of the session after all the four speakers have spoken.
Thank
So
you.
I'll go on to the next speaker. It's my pleasure an honor to introduce the second speaker for today's session, Dr. Andres Matoso, who is a professor of pathology, urology, and oncology at the Johns Hopkins University School of Medicine, where he directs the urological pathology division and the genitourinary pathology fellowship. He graduated at the University of Buenos Aires. He trained in urology before completing a postdoctoral fellowship in cancer biology at Cornell, and his pathology training was at Brown University. He did subspecialty fellowships at Brown and Johns Hopkins, and since 2017, Dr. Matoso is in Johns Hopkins and has been an integral part of the service there, reviewing more than 5,000 uropathology cases. His research focuses on molecular changes in bladder cancer, prostate cancer grading, and rare urologic tumors. He has authored more than 180 publications with multiple book chapters, including the WHO tumor classification. He is also a co-author of the Survival Guide to Prostate Pathology. He has lectured extensively nationally and internationally and is a widely recognized speaker for his contributions to urologic pathology. Dr. Matoso will be speaking on the very important topic of pathology reporting in urothelial carcinoma with its diagnostic and therapeutic updates. Over to you, Dr. Matoso.
Thank you very much for that kind introduction. Can you hear me well?
Yes, we can hear you.
Thank you very much. So today I'm going to talk about clinically relevant pathologic aspects of urothelial carcinoma. So the learning objectives includes recognizing the histologic subtypes and therapeutic implications associated with those, identify common pitfalls, and apply immunohistochemistry judiciously to avoid those common pitfalls. And finally, we're going to navigate some diagnostic challenges, both of the upper urinary tract and the lower urinary tract specimens. So why urothelial carcinoma pathology reporting matters clinically? Well, urothelial carcinoma, as you all know, is a very heterogeneous disease. It is very different patient from patient, and it is also very different within the same patient in different areas of the tumor and in the primary versus the recurrence. So pathologic classification and as detailed pathologic reporting is extremely important to establish the appropriate prognosis and to determine the best treatment for those patients. Those include BCG, chemotherapy, immunotherapy, FGFR inhibitors, and antibody drug conjugates. As more therapies are developed, more detail is required from us as pathologists to make this our report the most useful possible for the patient and the clinician. So in terms of histologic subtypes, they are divided into divergent differentiation and true variants or subtypes as they're referred in the latest WHO classification. The subtypes with prognostic implication or therapeutic impacts are the ones I'm going to talk about. But the ones with divergent differentiation and also relatively common, especially squamous and glandular differentiation, and we're going to discuss them in this presentation. So squamous differentiation is perhaps one of the most common divergent differentiations that we identify in patients with bladder cancer. It can be very tricky to identify or to recognize as separate, differentiated from conventional urothelial. Typically, what we would like to identify is a nest of cells, as we can see here on the screen, that develop keratinization, intercellular bridges, and that will be associated in general with worse prognosis. And these patients have a tendency to respond less to conventional urothelial carcinoma therapy. It's not the same to have urothelial carcinoma with a squamous differentiation as opposed to just pure urothelial carcinoma or pure squamous carcinoma. And in this retrospective study that we recently published from Johns Hopkins, you can see urothelial carcinoma pure and squamous cell carcinoma pure lining together side by side in terms of overall prognosis. But when the urothelial carcinoma develops squamous differentiation, then that is associated with worse prognosis. And it's considered to be the case because of advanced stage, high level vascular invasion, and higher rates of lymph node metastasis. Now, once we have squamous cell carcinoma of the bladder, it's always important to recognize the potential pitfalls in the differential diagnosis. No, it's not enough to call it squamous, but it's also we need to consider that some of these tumors might be extension from the GYN tract. One of the morphology clues to identify this phenomenon is that the tumor is underlying benign urothelium and kind of bulging the benign urothelium on top. An additional problem is that the squamous differentiation can also be GATA3 positive, as we can observe here in immunohistochemistry. But this morphology, the basaloid appearance, usually with central necrosis in a tumor that has high turnaround of cells, then that is a clue to have to rule out an HPV-related squamous cell carcinoma. And this is in the great majority of cases not a primary tumor of the bladder and can trigger a significant difference in management of this patient. Some of these squamous cell HPV-associated squamous cell carcinoma involving the bladder can even present with papillary lesions, and the clue diagnostically in these cases is this presence of a very basaloid morphology. And again, that's the clue to perform HPV and recognize that this is extension from a either genital or GYN tract tumor that is involving the bladder, and therefore appropriate staging and therapy will change and is no longer a primary bladder squamous differentiation. Next, I'm going to talk about glandular differentiation. Glandular differentiation, the great majority of situations, shows a intestinal phenotype, as you can see in this image, where it is almost indistinguishable from adenocarcinoma that we know and we diagnose in the gastrointestinal tract, either small intestine or colon or rectum. So it's imperative that in all these cases we add a note and saying that the extension from the GI tract has to be excluded clinically. By morphology and by immunohistochemistry is not so much that we can do, and there is significant overlap that can, if we rely too much on the immunohistochemistry findings, we might make mistakes. So that note is pertinent regardless of the immunophenotype. Of course, if this is accompanied with a conventional urothelial carcinoma, then it's easier to assume that this glandular component, even though it shows intestinal differentiation, it could be derived from that urothelial carcinoma. Now, one of the pitfalls in this group of tumors is mistaking Flores cystitis cystica with intestinal metaplasia and mucin extravasation presented as polyps or masses, and that with the excision that mucin dissecting the stroma can be suspicious for a low-grade mucinous adenocarcinoma. Now, the key there is not to confuse the glands with dysplastic glands. Look at the nuclei and separate these nuclei that could have reactive morphology versus a pencil-like and hyperchromasia of dysplastic intestinal type glands. Now, it has been long a question about whether intestinal metaplasia like this could be as a precursor of adenocarcinoma, and we have done a study that we looked at. We sequenced these cases, and we only identify in rare cases some mutations associated with colon-like adenocarcinoma, like APC mutations. So for the majority of patients, it is not, but we see some patients associated with dysplasia and that they later develop adenocarcinoma. Another pitfall with this benign intestinal metaplasia in the bladder is that, again, that mucin extravasation and that they can extend into the muscle, especially if it's in the area of the urachus, and this should not be confused with invasive carcinoma. And we see occasionally some cystectomies where the mucin dissecting the stroma mimics an invasive process. Now, when we are convinced that there is dysplasia, as we see in this case, then the next step is to distinguish this as an invasive carcinoma versus dysplasia only. And for that, we look at the architecture and the morphology of the glands. If the group of glands that have dysplasia, as shown here in the figure in the left, they are rounded and they have smooth edges. We look at the dysplasia and there is no evidence of invasion. Invasive intestinal type adenocarcinoma is usually characterized by features that we see in the image on the right, where the glands become an angulated border, the stroma is dysplastic, and the organization is irregular. So this is important, but this is the next challenge once we have intestinal metaplasia. And of course, some of these cases we have a very poorly differentiated component that also needs to be mentioned because it is associated with higher metastatic rate and worse prognosis. Next, we're going to talk about micropapillary subtype. Micropapillary subtype is relatively common as well, and it's always relevant. All these subtypes are only relevant in the invasive component. So when there is invasive carcinoma that we think about micropapillary, we do so when we identify multiple nests of tumor cells swimming in the same lacunary space. This lacunary space is driven by that reverse polarity that the cells acquire, where the mucin, instead of being sent into a gland-like space, is sent into the interstitium, and that helps dissect and make the tumor more aggressive. These tumors usually have more LVI, they have higher stage and lymph node metastasis, and the importance of recognizing this and not over-diagnosing it is that the urologist consider an early cystectomy. And the early cystectomy doesn't mean that the cystectomy happens at 7 a.m. It means that the patient will get a cystectomy even if it doesn't have invasion in the muscular areas propria. So some of the cases are very typical like this, where there is multiple little nests surrounded by those spaces, and the diagnosis of micropapillary component is easy, and there is extensive invasion. In some rare situations, the distinction with retraction artifact can be challenging, and other systems have also shown that the use of immunohistochemistry could be helpful. We don't usually use it, but occasionally you're going to have a small foci of that being the case. And so what you can do is the micropapillary, or you can do EMA and Decoding. And because of their reversed polarity, where the basal side of the cell is now towards the lumen, the EMA will have a reversed staining, and instead of staining a lumen of a gland-like structure, it will stain the periphery. And then the Decoding, again, normally you see more towards the base of the cells, and it has that distribution in the center if it is micropapillary. But well, if you have a retraction artifact, then those patterns are not seen. Here are some examples where diagnosing micropapillary is extremely challenging because it's a small focus, and there is a possibility that these clefts are retraction, but EMA shows that external distribution, confirming that reversed polarity. And the same thing in the second case, Decoding has that internal staining that is the abnormal pattern that is consistent with the reverse polarity, and it confirms micropapillary. Another aggressive subtype is the plasmacytoid. These are individual cells separated by a stroma, usually myxoid or mucinous. Those cells can be small, but they sometimes have a nuclear pleomorphism. They have eccentric cytoplasm, often filled with mucin. They mimic senior ring cell carcinoma of the stomach, or they mimic, for example, breast lobular carcinoma in a woman. They present in advanced stage, and they usually are higher stage at the resection because they invade in single cells in a way that the CAT scan and the MRI cannot recognize. So part of the aggressiveness of this tumor is the surprise that when it gets resected is much higher stage than the CAT scan or the MRI was showing. Here are several examples, and I showed multiple examples to demonstrate that many of these cases don't have a surface with the papillary component. So that also is important to raise the concern that whether this could be a metastasis. So I would say almost invariably we have to perform immunohistochemistry to exclude a metastatic gastric or metastatic breast cancer in these patients in order to confirm plasmacytoid subtype of urothelial carcinoma. This is a recent case we had in consultation where you see clearly the invasive component in the lamina propria, and appears that the muscular propria is free of tumor. But in this case, the immunohistochemistry now also is helpful in confirming that this is urothelial, but also it identifies a much deeper invasion beyond the muscular propria. But with the H&E, it could be extremely difficult to identify. So this is the variant that most commonly we had to use immunohistochemistry for to confirm Also has some caveats, like because they are epithelial cells, they're CD138 positive, and they look like plasma cells, so that should not make us confused that this is a plasmacytoma. But they do express other markers like A1A3 or CAM5.2 and GATA3, which is often positive. They have a tendency to be P63 negative. That could be a pitfall. They do lose ecadherin in about 50% of the cases, similar to gastric adenocarcinoma, but it's important to always exclude breast and GI origin by performing CDX2 and ER and PR. In general, bladder urothelial carcinoma have a low expression of ER, PR, so this is very helpful, especially getting the clinical history of female, but a lot of those women don't even know that they have lobular breast cancer, as it can go occult clinically. Additionally, some plasmacytoid or rhabdoid type of morphology would trigger the concern that this could be a myogenic tumor, so adding desmin and SMA is not crazy. Another highly aggressive form and relatively common, even though it makes less than 1% of all bladder cancers, is the sarcomatoid urothelial carcinoma. You all have seen it. It is usually associated with an epithelial component, but we are seeing some cases that are difficult to distinguish it from IMTs, for example. We have started to use MTAP, and there's going to be a study published, hopefully not so long from now, led by Dr. Baraban. And MTAP loss can be very helpful in this context, although it's not 100% specific. But when you see CIS overlying and spindle cell proliferation, your concern is whether this could be reactive, like an IMT, versus a neoplastic. The presence of MTAP confirms that the MTAP loss confirms that this is malignant. And not only that, it also shows that there is a molecular progression for the CIS overlying the surface towards the most aggressive component, that is the spindle cell component. So most recently, in the January issue of AJSP, we published this series of 136 patients with sarcomatoid urothelial carcinoma with emphasis on PT1 tumors. The urologists are often resistant, even though this is an aggressive subtype, to perform cystectomies in patients who have only T1 tumors. We had 10 patients with PT1 tumor, but we also have overall data from all the other patients, and you can see, consistent with previous report, heterologous differentiation, which means that if the sarcomatoid component shows bone or other type of lineage of differentiation, like chondral differentiation or angiosarcoma, they have a worse overall survival compared to those where the sarcomatoid component is just simple spindle cell. If you do surrogate markers of basal versus luminal differentiation, the prognosis doesn't change. So sarcomatoid most commonly comes along with CK5-6 positivity, more basaloid phenotype associated with squamous differentiation, but there is no clear difference. If you're going to make that distinction based on the immunohistochemistry, the prognosis is very similar. There is a lot of talk and emphasis about PD-L1 being highly expressed on sarcomatoid urothelial carcinoma as an alternative therapy for these patients. In our series, we had a split half and half with patients who have strong PD-L1 expression and those who don't. And then we only see a significant difference when that PD-L1 expression is really high, way beyond that 10% that is assumed as the cutoff for positive PD-L1 expression. Other markers of aggressiveness like LVI and stage remain consistent, but when we look at PT1 patients, they have significantly better prognosis, especially if they have gone to cystectomy. But on follow-up, those patients also develop metastasis in 30 to 40%. 30% of the patients, and then in our follow-up, 40% of patients were dead at 5 years, even though they had a PT1 tumor. The features that we identified associated with death with these patients with early sarcomatoid carcinoma includes high volume disease with sort of polypoid projections into the lumen, necrosis, and LVI. Talking about sarcomatoid, it's important to recognize that occasional sarcomatoid urothelial carcinomas will not demonstrate the typical spindle cell morphology or heterologous differentiation that is obvious. Here you see a case with CIS on the surface and an invasive component consisting of small cells with marked pleomorphism, but it gives an idea that it could be a small cell carcinoma, is deeply invasive in the muscle, we do synaptophysin, and is diffusely positive. but this is a case of a rhabdomyosarcomatoid carcinoma where the sarcomatoid component consists of rhabdomyosarcoma. So this is a pitfall because they express synaptophysin, and the clue is to realize that this small blue cell component is negative for cytokeratin. So now this gives us introduction to the small cell carcinoma. Is another very rare variant. It's less than 1%. It's aggressive. It gets early metastasis. It has same molecular alteration as small cell carcinomas in the lung with frequent TP53 and RB1 mutation. And it's important to recognize them because now neoadjuvant chemotherapy prostatectomy is the standard of care. So these patients need to get small cell specific therapy before going to cystectomy if we want the most appropriate outcome. In this study that we did comparing mixed versus pure small cell carcinoma of the bladder, here are some examples. You see the pure on the left and the mixed with squamous. Sometimes they are not completely distinct, but intermixed altogether. Morphology is similar to the lung with nuclear molding, indiscrete nucleoli, frequent mitosis, apoptosis. There could be a streaming, central necrosis, palisade at the periphery, everything that we see in lung, with also variable expression of neuroendocrine markers, as we can see here, so that it's indistinguishable from lung adenocarcinoma. They could also express TTF1, and a minority of cases will retain GATA3, confirming that this is coming from the bladder. One of the distinctions that the clinicians often ask when we have a small cell carcinoma is where is it coming from? And the response is sometimes we can say it's coming from the bladder if there is GATA3, if there is associated with other urothelial carcinoma, but then if we cannot tell, we say in real practical terms it doesn't make much difference because they all get treated the same. We find that RB1 loss is consistently a finding that can also be present in the non-small cell component, but is higher in the small cell component as opposed to the epithelial component. This is something that they share that indicates clonality, and the non-small cell component often that does not show neuroendocrine differentiation. So when we compare overall prognosis or survival, any component of a small cell is similar compared to those that are mixed, but patients who do get to cystectomy live longer. In molecular analysis, if we compare here to the left conventional urothelial carcinoma and to the right pure small cell carcinoma, the ones that are mixed, and we dissected them into the urothelial carcinoma component and the small cell carcinoma, we see that there is some overlap. And this indicates that at the RNA level, some of the conventional components of mixed tumors do express already a neuroendocrine signature, raising the possibilities that this kind of assay could identify patients that have already or are undergoing a neuroendocrine pathway of differentiation. And the question persists on whether these patients could benefit from neuroendocrine specific therapy. This is another way of showing the same thing with bars. So you see small cell carcinoma here. You see the urothelial carcinoma pure here, the urothelial component of mixed, and the small cell component of mixed, and the pure small cell component, how they gradually increase their neuroendocrine signature by RNA expression. So next, small cell carcinoma are now being compared to small cell carcinoma of the lung in terms of their classification based on transcription factors expression. We and the group of Sloan Kettering and other papers have recently come out where they make that parallel comparison. And here you see the different small cell carcinoma defined by their transcription factors. This can be detected by immunohistochemistry. And you see the ASCL1 is the most common and is the one that has the highest expression of neuroendocrine markers, and both PO2F3 is the one that is neuroendocrine low small cell carcinoma. And these will be those cases that we know are a small cell carcinoma. We do all the stains and we fail to prove that they are neuroendocrine with the stain. So it could be following this within this category. There are antibodies now, and in the future, this possible is going to take more momentum as we design better drugs that could target each particular subtype. And in that aim, we have also published a study where we look at the different subtypes, transcription of factor subtypes, and their expression for antibody drug conjugate receptors. Antibody drug conjugate receptors are drugs bound to an antibody that will get into the cells if the cells show that receptor. So if the receptor is not there, it's unlikely that will have an effect. But here we see that there is differential expression of antibody-drug receptor depending on the subtype of transcription factor-specific small cell carcinoma. And Hikmat from Sloan Kettering has done another study where they add the DLL3 that is now a target for Merkel cell carcinoma, is another neuroendocrine carcinoma, is highly expressed in ASCL2, and then this other one, PLCG2, in the POF2F, that is the neuroendocrine low, and that it has an aggressive behavior. So in conclusion, this is in early stages, but it might take more momentum as we develop more specific therapies. Nested urothelial carcinoma often invades deep. The key is that these are deceptively bland. They should not be graded. And they're often also very deep. Some of the variants are the large nested like this, but it has the same implication. They can involve the muscle, as we can see here. And another variant is the tubular morphology of these nested urothelial carcinoma, and here the key is not to confuse this with glandular differentiation. Nested has a peculiarity that is often PAX-A positivity that can raise confusion with GYN or nephrogenic adenomas. In terms of grading, we continue to follow the dual, the binary type of grading with low grade and high grade, where you can see the low grade with minimal atypia and the high grade with much more pronounced atypia. And this is supported by the WHO, but there are some pitfalls in patients that have less than 5% high grade. There can be a lot of inter-observer variability. We sometimes utilize Ki-67, but this is not the standard, and it does not define the grade, but it can be helpful when we think it's low grade or it's borderline, and we see that Ki-67 is high. In general, more than 10% is considered to be higher than what you normally see in low grade. And grading of upper tract tumors compared to lower grade, lower tract tumors are quite conflicting, and the biopsies have increased recently. The reason being is that there are a lot of conservative management for upper tract urothelial carcinomas. The difference with the bladder is that the bladder, once we get a papillary tumor, we resect it entirely so we can analyze and get an accurate grade. In the upper tract, because of technical difficulties, the specimens are often small, and we have seen that the discordance is much higher. And we want to alert the clinicians that this is a pitfall, especially if they're going to do conservative therapy, because that patient might develop invasive disease. Another pitfall is when the low grades have degenerative type of atypia. This degenerative atypia is characterized by smudgy nuclei, intranuclear vacuoles, and nuclear multinucleation. In this case, it's performing a Ki-67 and showing that those cells that have high-grade nuclear features but degenerative type of appearance are negative for Ki-67. In terms of, quickly, we're going to go with invasion and staging. The most important is separating what's T2 or earlier than T2, because those are the patients that go to cystectomy. So PT1A, there is emphasis to quantify that, and there are several methods. It can be quite tricky, but PT1A would be above the muscularis mucosa, PT1B at the level of muscular mucosa, and then PT2 below the muscularis mucosa. Here would be PT1C, but these are difficult sometimes due to orientation. This is an example of a perfectly oriented tumor where you see the non-invasive component, you see the invasion into the lamina propria, and then invasion into the muscle. I wish all the cases where this is it, but they're not. So there are different techniques to substratify the invasion into the different PT1 levels of invasion. And the idea is that quantification of it has a direct correlate with BCG response and outcome. And so the more invasive in the lamina propria, the less likely this patient is going to respond to BCG, and the more likely it's going to end in cystectomy. Now, some of the cases involve thin muscle bundles, and we are uncertain whether this is a PT2, and we need to clearly state this ambiguity to the clinician. In this study performed in 2010, about 50% of the patients who got a repeat biopsy when determining that muscle involvement was ambiguous, those patients then had PT2 in the repeat biopsy, but a large proportion of patients are lost to a repeat biopsy. So this is an area where we have to have a good communication with the clinician and a clear message that they need to have a repeat biopsy. We then perform a follow-up study to see what happened with those patients who had a repeat biopsy but had PTA or PT1. And those patients at cystectomy, first of all, 100% of patients that had a PTA or PT1 after an ambiguous for muscular dyspropia ended up in cystectomy. So they did try conservative therapy, but they failed. And it's likely that this at least represent PT1C tumor or extensive involvement of the lamina propria. When we do the cystectomy, we see that these patients with ambiguous muscular dyspropia invasion have rate of PT2 or higher, as cystectomy is comparable to patients with invasion of muscular dyspropia at front. So this is perhaps one of the other features that the urologist should start using to discuss early cystectomy with patients. I'm about
you have 5 more minutes, Dr. Matoso.
Yeah.
I'm sorry to interrupt. 5 more minutes.
I'm about to finish. So, and then talking now about upper tract, staging of upper tract is also conflicting. And for a long time, we have translated staging from the bladder into the upper tract, but they're anatomically significantly different. And the landmarks of in the kidney are very difficult with bulky tumors to identify. This is a study that we are now doing with one of our fellows, William Zhang, who's going to go next to Brigham. And the controversy about staging in these different upper tract urinary tracts includes that patients with PT2 or PT3 have overlapping outcomes. So for a long time, we have seen that the staging does not correlate with outcome completely like it should be in the bladder. And part of the reason is that landmarks are difficult to identify. There are different invasion patterns that can obscure the structures. And there is also controversy whether invasion of the fat in the peripelvic area is the same as invasive of the fat in the around the ureter. This could have clinical consequences because of prognosis and because of adjuvant chemotherapy decisions. So some of the studies, and I'm not going to go into detail because of lack of time, are listed here. But in general, they're trying to determine certain factors, like including whether invasion of the fat in the renal pelvis is the same as periureteral invasion of the fat, if invasion of the renal medullary tissue is the same as invasive of the cortex, or they should be separated into different categories. But one thing that we do have to be all aware of is the pitfall of overcalling or overstaging upper tract urothelial carcinoma when the tumor cells invade the tubules and into the renal parenchyma, but without invasion of the stroma. And this should still be considered a non-invasive urothelial carcinoma and not a PT3, or the patient will get unnecessary chemotherapy. So a little bit about utility, pitfalls and use of immunohistochemistry. You saw some of it as I was going along with the lecture, but what is it helpful to identify the subtypes, as I showed you some examples in the differential diagnosis, if you're thinking of metastasis and mimics. And we do not use it for routine grading. I would say we use occasional Ki-67 in cases that are borderline and difficult to classify. Some of the pitfalls include the loss of GATA3 or some of the markers in high-grade urothelial carcinoma, P63 negativity in plasmacytoid, and over-reliance in a single marker. We usually do 2 or 3 different markers, and also 2 or 3 of the other main differential diagnosis. And then what I see is as another problem with immunohistochemistry is overconfidence bias, overestimating one's diagnostic accuracy or expertise and not performing immunohistochemistry because you have seen enough. And any tumor in the bladder, even if it's coming from another side, it mimics urothelial cancer. So we have to be highly alert about detecting secondary involvement. The most common urothelial markers, GATA3 and uroplakin. GATA3 is extremely sensitive, but not specific. And uroplakin is extremely specific, but not sensitive. So in general, when we need uroplakin to be positive, rarely we find any staining. And this is another example of a secondary involvement of the bladder Similar to the cases I showed before, the clue is that the overlying mucosa is benign and that the tumor is underneath that mucosa. So then this should trigger, and in a man, the most common involvement is prostate. So doing the markers in that situation helps. But the same happens in women when you see the benign urothelium on the surface and the tumor underlying it without a papillary component, without CIS. And then we dig up about the history. We find out the patient had a history of breast cancer. That's how we do the appropriate markers to identify. And it can also happen even with sarcomas, like in this case of endometrial stroma sarcoma involving the bladder. Getting the clinical history is critical to performing the appropriate immunohistochemistry and making diagnosis. In the future, and we're already using some of these, but based on clinicians' request, there are several molecularly informing immunohistochemistry that will be used. And those include detection of FGFR3 mutation, usually in low-grade papillary tumors or upper tract urothelial carcinomas, because there are FGFR3 directed therapies. The determination of luminal versus basal, there has been a lot of research based on RNA, and immunohistochemistry still is not mainstream in clinical care, but it has some potential to be more helpful as new therapies arise. Antibody drug conjugates, as I mentioned, Nectin-4, TROP2, they have direct approval by the FDA to be treated without any routine testing prior to starting the therapy, but some clinicians are requesting them because they do not want to waste time or spend on a very expensive therapy. If the patient doesn't show any expression of the surface marker, then it's more unlikely that it will have any positive response. And all upper tract urothelial carcinomas get tested for Lynch syndrome because they have a low but higher risk of having mismatch repair protein deficiency. So with this, I'm finishing. So in conclusion, urothelial carcinoma subtypes matter. Recognize them are important. Report them. We do provide a percentage of it, especially for enrollment of clinical trials that could be relevant for deciding different therapies. Accurate grading and staging is also critical for management. We use immunohistochemistry as a guide, not as a crutch. It's always helpful, but in the context of the clinical history and the morphology. And molecularly informed IHC will likely be topics of future lectures with more emphasis in the decision of specific therapies. And with this, I thank you so much for your attention. And yeah, thank you so much.
Thank you very much, Dr. Matoso, for this very informative and practical lecture. A reminder for the audience, please feel free to submit your question through the Q&A tab. We'll address them at the end of the entire session. Now, moving on to our third lecture, it is my pleasure to welcome Dr. Liwei Jia. Dr. Jia is an MD, PhD, and is an associate professor of pathology at the University of Texas Southwestern Medical Center. Her career trajectory from foundational training in High Bay Medical University through advanced pathology residency at Case Western Reserve to double fellowship training in oncologic surgical and GU pathology at Memorial Sloan Kettering Cancer Center has positioned her among the well-rounded and innovative academic pathologists. Since joining UT Southwestern Medical Center, after her fellowship, her scholarship demonstrates impressive depth in both diagnostic expertise and research, with recent publications addressing molecular diagnostic, digital pathology, and the clinico-pathologic challenges of renal, bladder, testicular, and adrenal tumors. The title of Dr. Jia's lecture is Contemporary Highlights in Renal Cell Carcinoma, Surgical and Molecular Pathology. Dr. Jia, the floor is yours.
All right, thank you. Hello, everyone, and thank you for the next introduction, Dr. Premo. It's my great honor to have the opportunity of a talk on the subtype. But before we dive in, I want to just overview the classification of the renal epithelial neoplasm. We know it has been involved over the past several decades, not only from the 2 histotypes in 1974 to 21 histotypes in 2022, recognized by the WHO Blue Book. And also from the pure based on the molecular description to a sophisticated system to integrating molecular, genetic, and clinical data. And then there are some changes in the nomenclature relevant to prognosis. For example, the clear cell papillary renal cell carcinoma replaced by clear cell papillary renal cell tumor, and also the papillary renal neoplasm with reverse polarity, we consider subtype of papillary RCC due to their indolent behavior, although there are some metastatic behavior in rare instance reported by my former co-GU fellow at the MNCK, the excellent work from Dr. Gupta reported some metastatic case for the clear cell papillary renal cell tumor. But the malignant potential is very low. Both of them consider the indolence behavior. And then classification in oncocytic tumors still remain complex and challenging in our daily practice. The coproform RCC and oncocytoma is the main differential when you dealing with the oncocytic tumors. Although there's a eosinophilic solid cystic renal cell carcinoma is recognized by 2022 WHO as a new entity, and the EVT and LOT are listed under the other oncocytic tumors and the low malignant potential. But most of them are associated with mTOR TSC family alterations, which is a potential new therapeutic approach. All these tumors, all these three tumors show good prognosis, although there are some rare cases show aggressive behavior in like 5 to 10% risk. But in practice, there's the distinguishing between the three. Has no clinical impact on the patient management because there's no further treatment. The surgery is the only thing for the patient care. And then molecularly, it's well known that several pathways are pivotal for the development of the diverse renal neoplasm in the hereditary sporadic setting, as listed here. There are also there are evolving and emergent entity like F2 related RCC and more mTOR TSC alteration associated RCC are coming, like evolving and emerging, but not really recognized in the WG book yet. And then there's also a new category of molecular defined renal carcinomas with diverse histology and divergent biological potential and different clinical implications are recognized or introduced in 2022 WHO book. Because different from other RCCs related to the molecular pathways, their classification kind of highly based on the definitional molecular features. So for the limited time, I will discuss the 6 most clinical relevant entity in this group as listed here. First is MIT family altered RCC. Although it's initially recognized in the pediatric patient, the incidence also high, like 40% of pediatric patients with this MIT family altered RCC. However, the definite number of cases you might encounter in your daily practice is more commonly seen in the adult population, although the incidence is just 1.6 to 4.4% of adult RCC. However, the number is over 40,000 per year. In the current WHO book, the MIT family alteration carcinoma divided into TSF3 rearrangement RCC and TFEB altered RCC, which is also further subdivided into TFEB rearranged and TFEB amplified. Among these tumors, they show wide similar spectrum of morphologic features because they kind of activating the same the description of the similar genes. But there's also some unique clinical features. For example, TFE3 usually in the younger young adult. And then the prognosis is similar to clear cell RCC, but worse than papillary RCC in adults. TFEB arrangement RCC is the least commonly seen in the practice, but it's the most indolent. In contrast, the TFEB amplified some unique features of these entities in the older patients and some most aggressive and disease in this group. So the TFE3, which is the most common disease in this group, this typically from this tan yellow to gray tumor, can be necrotic and hemorrhagic. Morphologically, is the most characteristic morphology is the papillary structure lined by these large polygonal epithelial cells with abundant pale to clear cytoplasm, and showing this picture. And then with the study, we already know there's a more than 20 genes can be partnered with TFE3. And also there's also the number kind of still remain increasing over time. Also very unique features of this fusion gene is there's a specific fusion pattern may influence the morphologic features, immunophenotype, and then some outcomes. For example, in this picture, we see this ASPSCR1 RCC often features large discohesive tumor cells with voluminous clear to epithelial cytoplasm, well-defined cell borders, vesicular chromatin, along with abundant sumable bodies. In contrast, PRCC fusion gene typically has a less abundant cytoplasm, fewer sumable bodies, and a more compact nested growth pattern. And the normal gene, fusion gene, and then FPQ, those two entities usually mimicking clear cell RCC, and also with abundant subnuclear vacuoles mimicking clear cell papillary cell tumor. Both are less aggressive compared to another fusion partners, especially the PSA-PRC fusion gene. And the strongest correlation is seen in this MAT15 TFE3-RCC, almost always extensive cystic of note, of course, and also with indolent behaviors but only based on the limited data. However, we have to notice that or remember, although there's some correlation, there's with these different fusion genes, there's a significant morphologic overlapping among these tumors with different gene fusion. And then as I mentioned before, previously, the TFE rearrangement is less common compared to TFE3 rearrangement. But also similarly, also commonly seen in the younger adults, usually is a localized disease and then behavior more indolently than TFE3 rearrangement. However, again, this always is because of rare, the data is still limited. And also you can see the growth is a kind of a tan yellow brown in color with some multinocular appearance. the most characteristic morphology for TFEB translocation or rearrangement RCC is MALAT1 fusion gene. Because there's a typically shows this classic biphasic morphology, nested epithelial cells featuring two cell population. One is a larger epithelial cells with a clear to eosinophilic cytoplasm nested to acinar architecture. There's also smaller cell clusters around base membrane material. However, although there's still very significant morphologic overlapping among them. And then other fusion gene with TFEB rearrangement showing a diverse morphology. Less likely you're gonna see this dual cell population. In addition, they kind of mimic either for this one the TCTB fusion gene, they more commonly mimic epithelioid AML. The WSR1 and then CLTC fusion genes commonly mimic CCRCC, which causes some diagnostic dilemma. There's also some unknown fusion showing this as more predominant epithelial eosinophilic cytoplasm, ranging into papillary and then granular cytoplasm as well. Another thing also, there's even in the same tumor, there's also intratumoral heterogeneity in the morphology, not limited to the TFE-B, also TFE-3. You see in this example, you can see some area kind of mimicking the clear cell cytoplasm. The left lower, you will see there's a tubular structure with a very eosinophilic cytoplasm. On this one, there's even like multinuclear giant cells with prominent nuclei, some perinuclear halo, kind of mimicking FH deficient RCC. TSVB amplified RCC is quite of a unique features, make this entity stand out in the group. For example, occur in the older population, median age like 65 years old, 3 times more common than the TFEB, and frequently presenting with advanced disease, like a local stage or metastatic disease. But however, the heterogeneous and less distinguished morphology present some diagnostic challenge if you are not really familiar with this entity or not consider in your differential diagnosis. The morphologically, their tumor showed a wide spectrum, frequently with a high-grade anesthetic and solid and papillary features, and shown in the picture. So there's also wide similar to another disease in the same group. TFEB amplified often displays some like wide morphologic spectrum with some high-grade eosinophilic and papillary features with solid nested alveolar and pseudopapillary structure, usually in the combination, and prominent nuclei abundant eosinophilic cytoplasm. So with that, we know there's even in the same group, there's quite of overlapping. That's why when you dealing with the real cases, you have to consider in the differential and maybe some intensive IHC is needed for you to make a definitive diagnosis. All these 3 diseases show like under expression of epithelial markers if you use A13, CAM52. Sometimes there's just usually negative, or even sometimes there's a focal positivity. However, in rare cases, MA might show diffuse positivity. And then you have to recombine some metastatic markers and then calcium K and GPMD is newly developed markers by recently. And then TFE3, TFB, although the antibody is available commercially, however, there are some technical difficulty to perform reliably. So usually in my practice, I usually combination of epithelial markers and the metastatic markers, K17K and GPMB. Other marker list here just for the differential diagnosis. And then we know fish, if you really concern suspicious for MIT family RCC, the fish is a gold standard for diagnosis to identify the translocation involving TFE3 or TFB or the TFB amplification. However, we have to keep in mind there are the pitfall regarding the chromosome inversion, especially if involving this 4 fusion genes combination fused with TFE3 or TFEB, because there's a kind of an intra-chromosome inversion. The separation is the distance of separation is less. It hesitate to really call the positive. Then if the morphology really concerned about the translocation, or the TFB amplified, you have to do some further workup. There's a newly developed some RNA-ish by Dr. Mahara, TRIP63, and then also you can go for with RNA sequencing, and also use fish using specialized phosphate break part protein probe to identify this chromosomal inversion. FH deficient RCC is a rare disease. However, it's really aggressive disease for patient to have. Initially, FH deficient is a part of hereditary leiomyomatosis and RCC syndrome, but can also occur sporadically. The papillary, in the ideal world, the papillary growth pattern with prominent eosinophilic nucleolus with paranuclear halo is the hallmark morphologic features. And then with that morphology, you might want to pursue FH to confirm your morphologic impression. However, no surprisingly, there's also a virus growth pattern, usually in combination in the majority of cases. You might see solid cribriform-like pattern. There's a papillary growing in the cystic space. Even there's a intracytoplasmic vacuoles quite prominent. To make even worse or complicated, in rare cases, FH deficient RCC manifests as a low-grade eosinophilic renal neoplasm features, kind of further confirm the diagnosis. Again, this is a rare disease, poor prognosis, with a wide growth pattern, keeping differential if you see such diverse histology features in the tissue. Even in this case, this renal biopsy case, this tumor showed a very subtle eosinophilic micronucleoli, but the lack of paranuclear halo. There's an atypical, no papillary structure at all. So just to perform some ancillary study, including FH, lost. Sometimes you might need 2IC if the morphology impression highly suspicious for FH. However, FH still remained by HC. 2IC is your friend. However, maybe not widely available in the lab. Again, you can just pursue another further molecular to confirm your morphologic impression. As stage B is extremely rare. There's also occur in the wide age range patient of the median age of 35. Usually, most of the cases, patients showed asymptomatic, and the morphologic is a low grade. Majority cases favorite prognosis. However, if you have to check if there are any high grade nuclear grade, the sarcomatoid differentiation, or some necrosis, those indicate high risk of metastasis, might require radical nephrectomy or close follow-up. The diagnosis is crucial for patients and their relevance because there should go to a genetic constellation. And this one also is rare. However, the morphological features can be still wide, like variation, including this choroid, solid nests with microcystic features, papillary structure, even some high-grade prominent nuclei, and even micropapilla formation. Again, in the pink tumor, high-grade, you have to think about this ADH deficient RCC. ADHB is quite a reliable IHC to help you make a diagnosis, especially you have a nice internal control showing the positive staining of ADHB. ARC rearrangement RCC is another rare entity characterized by rearrangement of ARC gene with the different fusion genes. Initially, they saw this young patient with sickle cell trait has been identified a group of increasing frequency of ARC RCC, especially this ARC gene fused with VCL. Demonstrate some morphological features, including papillary reticular growth, prominent plasmacytic lymphoplasmacytic infiltrate, intracytoplasm vacuolation. Later on, there are some multiple partner genes demonstrate variable morphology, exhibiting polygonal rhabdoid cells, signal ring cells, or spindle cells. Those various partner genes are less frequently associated with the sickle cell trait, but more frequently seen in the young adult patients, not young teenagers. ALK clones 5A4 or DF3 is a positive in this entity. Of course, you have to rule out other entities mentioned before in your differential. Further molecular studies, including FISH, PCR, or NGS, can be helpful to confirm the gene arrangement and characterize the specific fusion partner. The last one is SMARCB1 deficient RCC. Again, the rare and the high-grade RCC arising in the distal nephrin, most frequently seen in the younger African patients with hemoglobinopathies, is primarily sickle cell trait or hemoglobin SC diseases. Usually, the patient often symptomatic present or advanced disease quickly progress even with surgery and chemotherapy. It's the SMART deficient RCC have a diverse microscopic appearance with features ranging from reticular or sock cell or yolk cell tumor-like cremiform, tubular papillary, solid sheaths, infiltrating tubules, and individual cells in the desmoplastic stroma. Mucin and stroma myxoid changes is also common seen. Again, immunostains, the helpful ones is SMARCB1 loss in majority of the cases, and then in 50 to 60% of the tumors show positive for all 3-4. Although we go over through these all RCCs, they are rare. The clear cell RCC, papillary, and the chloroform are the three most common subtype of RCC. And then if they are local, the surgery is still mainstay of management for the patient. Although there's a trials showing there's an adjuvant pembrolizumab used as a adjuvant therapy after the nephrectomy if the patient has a high risk of a recurrence. However, this digital trial not is really routine practice. And then for other RCCs, especially FH and SDHB, there's the constellation, if a local, the genetic constellation is very important to the patient and especially for the patient's relevance. If there's some metastatic or advanced disease, the treatment options has expanded remarkably over the past decades. At least here, the ICI, the immuno checkpoint inhibitor play a very important role over multiple subtypes of RCCs. There's also specific target therapy like ORG inhibitors for ORG re-enriched RCC and the EHZ inhibitors for SMART-B1 deficient RCC. Although they are rare, but still it's important to distinguish from other differential diagnosis from other differentials since they all have some significant overlapping morphologic features. All right, I think I ran up for this RCC, and then based on the requirements, the next I'm going to talk about the renal mass biopsy. Although the needle biopsy of the renal mass increasing over the time, however, still not a routine practice for all the renal masses. Often only in some specific clinical settings for the risk restriction or the clinician try to find out the etiology before pursue a surgery, or the patient has some solitary kidney or some specific scenario. Have to make sure there really is a malignancy before the surgery. That's why the patient might receive some needle biopsy of the renal masses.
Dr. Jia, sorry for the interruption. 5 minutes left.
Okay, I'm gonna finish very soon. This is a really big topic, but I wanna dissecting into several scenarios. If the renal biopsy course you received show very classic morphology, that's gonna easy pieces for you to diagnosis even in the biopsy based on the cytologic features, either the clear cell, eosinophilic, or some what's the prominent growth patterns like a papillary. So if again classic morphology, clear cell, I think everyone here gonna very familiar with the classic morphology, so you're gonna really easy to diagnose is clear cell. And then clear cell papillary renal cell tumors, usually we don't diagnose in the biopsy because the sample issue. But if you see the small tumor, a lot of cars showing the similar morphology as a CCP-RC, and you do a GAS3 diffusely positive, you might confidently to call the CCP-RCT, or maybe you show it in the differential. And then the AML is not RCC. However, you might see some cause because of fat poor clinically concern for RCC. And the chloroform and then the papillary RCC. Of course, the morphology is good. You might still use some immunostains, at least here, to further support your morphologic impression. The difficult cases is the tumor with unusual morphology, where you have to really thoroughly evaluate the cytologic features. The growth pattern is a combination, is prominent, and also some high-grade features. And then in conjunction with the clinical data and the imaging data as well, to help you to form some differential diagnosis. Under this unusual morphology, you have to think about uncommon morphology of a common RCC. For example, this one, it shows some rhabdoid features, pink cytoplasm, there's a discohesive high-grade features. And then in another core, you see some low-grade features. So in the classical morphology of clear cell RCC, you did some C9 kind of support your diagnosis. So there's just the uncommon variant morphology of a common RCC. And then later, you have to think about some uncommon but well-differentiated RCs, and we discussed previously the translocation, the FH, SDH, ORC, and the SMART B1. Again, there are some rare, but there's a clinical indication. Last but not the least, you have to rule for the unusual morphology. You have to rule out other primaries of metastatic. In the kidney, the urothelium carcinoma, you have to rule out because there are significant different measurement for this patient. Use the markers here, and the metastatic scenario is less, but still consider if the morphology is really unusual. Check the history, and you might use some organ-specific IHC. And lymphoma, not common, but rarely occur. Again, you have to think about stepwise approach when you have this unusual morphology. Just summarize here. Morphology is the key to perform your differential diagnosis. Check the cytology, growth pattern, the high-grade component, and for the common RCC, use some common markers to support you and rule out metastatic. And then the rare RCC, of course, sometimes you did all the things, still cannot really diagnose with confidence, maybe further proceed of FH sequencing, or even in your differential diagnosis, in your comments, mention the differential diagnosis to help the oncologist or surgeons. And then last one, even they are rare, but they are still rare tumors. Some clinical mimicking RCC, imaging these cells mass, they did a biopsy. It turned out not really RCC. For example, there's the first two is the real cases in my practice. One is the well-differentiated neuroendocrine tumor, mimicking peptide RCC. The right one, the top right, is the mixed epithelial stroma tumor, showing this very cystic lesion lined by this epithelial cells. And another one is from, I think, Dr. Williamson. There's the renal splenosis, rare, but if you have that in your mind, do some markers, it's gonna help you. All right, that's my last slide. Thank you.
Thank you, Liwei, for that very extensive and very, very lucid talk about renal cancers. We move on to our next speaker. Our next speaker is Dr. Tamara Lotan. Tamara is a professor of pathology, oncology, and urology at the Johns Hopkins University School of Medicine. Her areas of clinical expertise, as we all know, is urological pathology. Dr. Lotan received her medical degree from the University of Chicago Pritzker School of Medicine. She completed her residency in anatomic pathology at the University of Chicago Hospitals and did a fellowship in urological pathology at Johns Hopkins University School of Medicine. She is a urologic pathologist and a physician scientist whose laboratory studies tissue-based predictive and prognostic markers in prostate cancer. The group also has a particular interest in molecular contributors to prostate cancer health disparities. They also study mTOR signaling pathways and its role in tumorigenesis, with focus on renal oncogenesis. Dr. Lotan is engaged in research training and is a co-PA of Optic T32 study in pathology, enabling pathology residents to engage in 2 to 3 years of laboratory research, which I think is very, very important in the current era of pathology training. She's currently the Deputy Director of Research Affairs in Department of Pathology. She would be speaking on a very, very important topic of an intersection of precision medicine and surgical pathology as it applies to clinical genitourinary oncology practice and the utilization of molecular tests. Over to you, Tamara.
Wonderful. So thanks so much for the invitation, and thanks to everyone who's stuck around. Hopefully this will be quick and kind of a different take from the prior 3 talks, where I'm going to really focus on molecular biomarkers in GU pathology, and particularly focus on kind of a clinical guidelines informed approach, focusing on the NCCN, the National Comprehensive Cancer Network guidelines in the US, which, are not universally adopted, but I think in many ways parallel other guidelines across the world. And I'm a member of the Prostate Cancer Guidelines Committee, so I'm going to focus a lot on prostate, where I think the molecular biomarker guidelines are much more well developed. But at the end, I will also touch on the guidelines for urothelial carcinoma and renal carcinoma. So just to start, a quick reminder that there are different types of molecular biomarkers. Of course, pathologists are very, very familiar with diagnostic biomarkers. We've heard about many of these IHC-based biomarkers in prior talks, and also molecular biomarkers that are diagnostic, for example, in renal cell carcinoma, as we just heard in the last very nice talk. But the biomarkers that really pique the interest of clinicians tend to be either prognostic or predictive. And I think there's really an increasing emphasis on predictive biomarkers among those two. So prognostic biomarkers estimate the risk of developing a particular oncologic endpoint. So it could be eventual metastasis or biochemical recurrence in prostate cancer. And hopefully they're actually independently prognostic so that they add to standard clinical pathologic factors. And they're typically used for sort of treatment intensification decisions. So for example, you could use a prognostic biomarker in prostate cancer to help determine whether a patient should stay on active surveillance or should move to definitive therapy, or you could use one to determine whether to do short or long-term, for example, androgen deprivation therapy in addition to radiation. And you could see here, in the panel A, kind of what the prognostic biomarkers look like in terms of biomarker positive patients doing better either when they're treated or untreated than biomarker negative patients. So kind of regardless of treatment, it gives an estimate of outcome. Predictive biomarkers is really what the NCCN guidelines are focused on. And I would say going forward, that's probably most of what we'll see in the guidelines. These identify a group of patients that derive either increased or decreased benefit from a specific therapy. So panel B beautifully illustrates a predictive biomarker where biomarker negative patients do not receive any benefit from the treatment, whereas biomarker positive patients do receive a benefit from the treatment. And so these are obviously critical to guide therapeutic decision-making. As I said, I would argue prognostic biomarkers in prostate cancer also have a role to guide whether to stay on active surveillance or not. But I think the guidelines are really looking at predictive biomarkers. So if we're going to have a laboratory test that helps to determine treatment, we need a very high level of evidence supporting that test. And so I think the era of, biomarkers just being discovered in individual labs and tested on a single institution cohort is over. We're really seeing that biomarkers need to be validated, ideally in a prospective randomized clinical trial where they've actually been integrated into the design. So you give the patients a biomarker and you either give them the treatment or do not give them the treatment, and you see if they have more benefit from the treatment based on their biomarker results. If these types of trials are really only starting to get conducted and maybe just starting to be finished in prostate cancer, some of the early ones, and really have not reported out for the most part. So until now, in prostate cancer and in many other disease types, the guidelines have really focused on biomarkers that are tested in a post hoc analysis of trials, typically requiring more than one trial with the same results. So that's looking back at a trial that was designed for some other purpose, testing a biomarker retrospectively in that trial, and hopefully seeing a similar result across several trials in this post hoc analysis. Okay, so now diving into individual disease types, we'll look at prostate cancer first. So in terms of next generation sequencing, of course, there's germline sequencing testing for constitutional variants, and then somatic sequencing, and we'll cover both of those. In prostate cancer, germline sequencing is recommended if the patient has a family history, which you can just see how the NCCN defines that. It's a family history of either early onset breast cancer, male breast cancer, ovarian cancer, or multiple first or second degree relatives with prostate cancer and or breast cancer. If the patient does not have a family history positive for any of these specifics, then we still are recommending germline sequencing in 2 clinical scenarios where I think the pathologist can play an important role in reminding clinicians about the significance of this. One is in high risk or very high risk localized prostate cancer. So essentially all grade group 5 and even grade group 4 disease would qualify as high risk. And also metastatic disease, either regional or distant. And the reason that pathologists can play such an important role is we know even in the US, in academic settings, only about 10% of patients with localized disease who meet these criteria, or a third of metastatic patients are actually receiving germline sequencing, which is kind of astounding. If you go into rural settings or more population-based settings or internationally, the numbers are even lower. So I think pathologists really do play a central role in reminding clinicians about the importance of germline testing in this setting after we make diagnoses that we know are relevant for germline testing. Germline testing should be done with a multi-gene panel. It should include sequencing assays for genes in the homologous recombination repair pathway for HRD alterations or the mismatch repair pathway. So really looking for DNA repair alterations in the germline. And the reason is that those are the most common germline alterations we see associated with prostate cancer. They're associated with a higher risk of prostate cancer and also a higher risk of metastatic prostate cancer. So you can see that the risk of these pathogenic germline mutations goes up incrementally from low risk prostate cancer to higher risk localized disease to metastatic disease. So more than 10% of patients with metastatic prostate cancer are carrying a germline alteration in one of these DNA repair genes. And you could see those over on the right side of the screen. So BRCA2 is mentioned in an earlier talk, is the most dominant one. ATM is second most common, then CHEK2 and BRCA1. Once a patient has had testing, even if their testing is negative, if they have a strong family history or a variant of unknown significance, so no pathogenic mutation, but either of these two, it's still recommended that they get genetic counseling. Certainly, if they have a pathogenic mutation in one of these genes, they need genetic counseling. And the goal is to really do cascade testing in the rest of their family members, particularly their first-degree family members, and of course, design, personal cancer screening protocols for these patients. In terms of somatic genomic testing in prostate cancer, so that's testing that's done on the tumor sample itself. That's only recommended in the metastatic setting, either N1 where it's considered or in distant metastatic prostate cancer. Again, you need a panel, a next generation sequencing panel that includes both homologous recombination repair and also MMR mutations. In metastatic prostate cancer, it's suggested to also get the tumor mutational burden, which of course can be an indicator if it's increased of underlying mismatch repair defects. And then to accompany this sequencing, you could do mismatch repair testing by another parallel method, either by immunohistochemistry, which is what we do at Hopkins, or you could do an MSI, microsatellite instability testing, and it's really critical that that be sequencing based. So it should be part of your next gen panel, not PCR based. It turns out that the PCR panels that we develop for colorectal cancer are not very sensitive in prostate cancer. The recommendation is to use a metastatic biopsy for testing, so you can remind your clinicians of that when they ask you to select a sample for sequencing. Often we don't have a metastatic biopsy available, so we go back to the primary diagnostic material. They can also use circulating tumor DNA. Of course, that's confounded by hematopoietic clonal alterations, so you have to be a little bit careful there. And the reason we do this testing is that while we said 10% of metastatic tumors have germline mutations in DNA repair genes, another 10% have a purely somatic alteration, so just in the tumor. And of course, this is important because it's predictive for therapy response. And so here's a little bit more about why it's predictive. It's so the presence of underlying HRD mutations, particularly in BRCA2, is predictive of response to PARP inhibitors. So in the setting of metastatic castration-resistant prostate cancer, that gives clinicians another tool in their toolbox. We now know with more developing trials that not all of these HRD mutations are equally responsive to PARP inhibitors. You could see on the right side that patients with BRCA mutations respond to this PARP inhibitor, rucaparib, but patients with ATM mutations, which is the second most common HRD mutation and was thought to sensitize to PARP inhibitors, are not actually responding super well to PARP inhibitors in many trials. So we may see some refined guidelines in the future there. These HRD mutations are also implicated in sensitivity to platinum-based chemotherapy. We heard earlier on about intraductal carcinoma being associated with BRCA2 loss, and that is true that we see more intraductal carcinoma in patients that have biallelic BRCA2 loss. But this has really fallen off the guidelines. Intraductal has fallen off the guidelines as an indicator for sequencing because there really isn't, there are not good studies suggesting that independent of grade, the presence of intraductal carcinoma is predictive of underlying BRCA2 mutation. We know high-grade tumors have a high rate of these mutations, and adding intraductal is not, there's no good evidence right now that that gives a higher risk of underlying BRCA2 alterations. So that's changed a little bit in the guidelines. This is just a summary of the different therapies that are available now and have been FDA approved, all in the metastatic castration-resistant prostate cancer setting. You could see that the indications for therapy in terms of which genes are mutated are slightly different, even though these are all PARP inhibitors, with the emphasis that really it's the BRCA2 and BRCA1 patients who are probably responding. And some of these other mutations, many of them may have been sort of inadvertently included, although some of them may be somewhat responsive. There's also important to screen for mismatch repair deficiency mutations, and of course the germline analogy for that, which is Lynch syndrome. These are somewhat a little bit less common than HRD mutations, with 3% of tumors overall, even less than that, having an underlying mismatch repair mutation. But again, as you go into higher grade disease or higher more aggressive histologic subtypes like ductal carcinoma or metastases, we see a higher rate of underlying mismatch repair deficiency. Of course, that this is important, not because it's particularly prognostic in these high-grade tumors, but because it predicts for response to anti-PD-1 therapies like pembrolizumab in particular. About half of these patients respond to pembro, and they don't have a very long and durable response the way we see in colorectal cancers, but they do get a median progression-free survival of around 6 months. In practice, we suggest at Hopkins at least doing mismatch repair immunohistochemistry in all of our grade group 5 tumors, as well as our ductal carcinomas and of course our metastatic cancers. And we partly do this just because we know so many patients are going to fall through the cracks in terms of getting the appropriate sequencing down the line. So if we can catch even a small number of cases with mismatch repair deficiency up front, that can be helpful in terms of really suggesting to the clinician the patient needs germline sequencing. And that's because about a quarter of the cases with loss in the tumor will have underlying germline mutations, which of course is indicative of Lynch syndrome. Okay, so just very quickly, neuroendocrine prostate cancer is really a diagnostic category we've already heard a little bit about, but that is prognostic and predictive. So it's very important to get that diagnosis correct. We know that small cell carcinoma in the prostate, is very, very rare in the untreated setting, much more common in the post-treatment setting, particularly as we've introduced more potent androgen receptor pathway inhibitors. And these tumors tend to be androgen receptor, or tend to be androgen tend to be ADT unresponsive, so unresponsive to androgen deprivation therapy and potentially platinum responsive. But in the treated setting, the diagnosis actually can be very challenging because there are a lot of cases that have kind of a mixed phenotype between adenocarcinoma and small cell carcinoma. So when we think about molecular markers to guide us in the diagnosis of neuroendocrine prostate cancer, I have always suggested we put them in these 3 buckets. We have neuroendocrine markers, which will be familiar to everyone. We have androgen receptor kind of pathway activation markers, including AR and some prostate-specific markers that most folks may already have in their labs, like NKX 3.1, and then cell cycle markers. And the classic neuroendocrine prostate cancers are neuroendocrine marker positive. They're androgen receptor negative or downstream markers of AR negative, and they're high in proliferation. Recent guidelines that have come out for analyzing metastatic prostate cancer samples have suggested that we really do 3 types of assessments on a metastatic sample. So we first do a morphologic classifier. Is it classic adeno? Is it classic small cell carcinoma? Is it something in between, which we can just, label as poorly differentiated carcinoma? Or of course, there could be sarcomatoid or, adenosquamous or other subtypes. Then we do the androgen receptor signaling panel, which is AR and NKX 3.1 as currently recommended, and report the tumor as either AR positive or negative, or report out where we see discordances between these two. And then do some neuroendocrine markers and report those, and then also Ki-67. And that kind of gives the clinician sort of the maximum, by being very descriptive, they have sort of the maximum leeway to tailor therapy for that patient, either more as a neuroendocrine prostate cancer where they stop androgen deprivation therapy or perhaps focus on platinum therapies, or more as an adenocarcinoma. And of course, I think we really need a lot of clinical trials moving forward. In practice, I always teach folks that, if a case is not very clear-cut small cell carcinoma, and especially if some of these AR markers are positive, it's beneficial to the patient to not rule out an adenocarcinoma so that they can at least get a trial of an AR-directed therapy, which is, of course, has very minimal side effects compared to a platinum-based therapy, for example. Finally, in the last few slides, there's some predictive transcriptomic biomarkers in prostate cancer that many have probably heard a lot about. I think there's a real emphasis now moving away from using these as prognostic biomarkers, largely because they have really not been studied in the most important prognostic context, which is active surveillance patients. So although they're marketed for this, they're really not studied adequately in this context. And they probably don't perform very well here. There's a kind of an emerging interest in whether these markers may be predictive, again, for patient subsets where we should intensify therapy. So, for example, intermediate or high-risk patients by a genomic classifier, an RNA-based classifier, may get more benefit from therapy intensification, such as addition of ADT to radiation in the salvage setting in this trial. But they're still not recommended as predictive in the NCCN guidelines. There are emerging digital pathology biomarkers. I won't spend much time on these except to say, similar to the transcriptomic markers, there's a lot of interest in whether these may be predictive for patients who could benefit from therapy intensification, but they're still not really recommended as predictive in the NCCN guidelines. So we're still awaiting those integral trials. Okay, just a few slides on the last 2 tumor types. So in urothelial carcinoma, there's much a little simpler guidelines. So we consider germline testing for patients who have a younger age at presentation or a personal or family history of Lynch syndrome-related cancers. Dr. Matoso mentioned at Hopkins, we routinely do MMR-IHC on upper tract urothelial carcinomas, but that's not in the NCCN guidelines yet. The risk for urothelial carcinoma and Lynch syndrome patients varies a lot by underlying gene mutation, with the highest risk in men who have MSH2 pathogenic variants, kind of intermediate risk for MLH1 and MSH6, and actually no evidence for an increased rate of urothelial carcinoma in PMS2 variant carriers. Somatic testing in urothelial cancer is not recommended for patients who have resectable muscle-invasive bladder cancer, so patients going to cystectomy or non-invasive or non-muscle invasive bladder cancer. There's emerging evidence, and I think we'll hear more in the next few years, about ctDNA testing as a kind of a marker for minimal residual disease after cystectomy. But that data is still maturing. There was a recent publication in the New England Journal for this IMvigor11 trial, which showed that in the ctDNA positive patients, they benefited from additional intensification with atezolizumab. In the metastatic or unresectable setting, there are some limited recommendations for somatic sequencing that includes FGFR mutation testing for an FGFR inhibitor, IHC for HER2, which I'll mention in the subsequent slide, and then some very limited settings for patients ineligible for platinum to get PD-L1 IHC, and of course MSI and MMRD testing in the unresectable muscle invasive setting are recommended. This is just a reminder about HER2 in this setting for this recently tested antibody drug conjugate targeting HER2, and we use the GI HER2 guidelines to do the evaluation. Lastly, renal cell carcinoma, most of the molecular testing that's clinically actionable, as mentioned in the prior talk, is around heritable syndromes that increase predisposition for renal cell carcinoma. So young patients, multifocal patients could get germline testing. And of course, if we identify a tumor that we know is part of a heritable syndrome, so if we make that diagnosis, that patient should also get germline sequencing. So much of the molecular testing that we have available that we heard about in the previous talk is really only therapeutically critical right now, at least in the guidelines for these heritable tumor syndromes, insofar as they indicate the patient has an underlying germline alteration. There are, for these heritable syndromes, a few specific therapies that have made it into the guidelines: tyrosine kinase inhibitors and some other inhibitors for HLRCC, mTOR inhibitors for tuberous sclerosis, and HIF-2 alpha inhibitors in VHL syndrome. So take-home points, NCCN recommended molecular tests are almost entirely for predictive biomarkers, and I think this will stay the same moving forward. These need to be studied really in integral prospective trials. In high-risk localized prostate cancer, like grade group 4 or 5 or ductal, pathologists should really be reminding clinicians to do germline sequencing and should also be considering performing MMR IHC. Metastatic prostate cancer needs both germline and somatic sequencing, also MMR IHC, and some workup to rule out neuroendocrine prostate cancer if there's even a low index of suspicion for that. And then in bladder cancer, germline sequencing if there's suspicion for Lynch, somatic sequencing in the metastatic setting, and in kidney, really focusing on these hereditary syndrome-associated tumors. And with that, I think I ended hopefully almost on time.
Thank you, Tamara. Yes, I think thanks for your amazing talk and also a very insightful perspective on where the field is going and what we need to know, at least in terms of evolving NCCN guidelines, and also sharing messages for practicing pathologists. So thank you, Tamara. And I think thanks to all our speakers. Santosh, Fadi, and I will now begin our Q&A session. Now, we do have several questions, and I think thanks also to our audience and participants who actually have stuck around and from all over the world. I know it's very late in some parts of Asia right now. I think we'll begin with my first question to Tamara, if that's okay, Tamara. And my question for you is just in tune with what you mentioned. Could you just please share, like, what are the specific instances in which you think our practicing pathologists, whether they are in academic practice or in community practices, like when should they pick up the phone and reach out to the clinician? Like, what are the main recommendations you have when you think it is imperative that a communication with a clinical colleague should not be missed in terms of an intended or a needed molecular workup for any patient with GU malignancy?
Yeah, I mean, I would say we communicate, certainly, we do this routine MMR IHC because that's so inexpensive and, does catch a small fraction of patients. So all of those cases, if we have an MMR deficiency, I'll definitely pick up the phone and make sure they have a recommendation in writing for germline testing. Again, about a quarter of those patients will have Lynch syndrome. Neuroendocrine prostate cancer, I think, also can be very challenging, especially if we're sort of in that poorly differentiated category, torn between adeno and neuroendocrine, and we have some kind of mixed phenotype. Maybe it's NKX positive, but wildly INSM1 positive and highly proliferative. I'll also talk to the clinician and often recommend sequencing because, if we see RB loss or P53 mutations, that can be helpful in that setting as well. We also do have RB-IHC, which I think is useful. And then obviously the, same thing goes for the hereditary, renal predisposition syndromes. Make sure you make a phone call about those in terms of germline sequencing. I think most people will make a comment in their report as well. So I think those are kind of the major areas. And then, when I'm on a tumor board, I just try to recommend, always remind people, and you'd be surprised how many times clinicians just sort of forget it in the chaos of the case. Oh, this guy has 2 relatives with ovarian cancer. He should definitely get germline sequencing, or it's super high grade or looked very inflamed. So I'm worrying about, MMR. So I think just making those comments can be helpful because you'd be surprised how often that gets lost as they're dealing with the immediate management.
Thank you, Tamara, for summarizing those points for our audience. And I think we feel the same. Actually, sometimes even discussing the obvious with our clinical team can sometimes really trigger additional, very important steps for clinical management of patients. Over to you, Santosh.
Yeah. I'll pick up a question from the Q&A for Dr. Matoso. Dr. Doa has asked that how do you diagnose large cell nested urothelial cancer? Can it be confused with a inverted non-invasive papillary lesion?
Yes, absolutely. And I think it's mostly once you have muscle invasive that it becomes obvious that it's large nested. But yes, some cases are extremely difficult. And you just have to, if there is ambiguity and we're not certain, then we just report that and hopefully additional tissue will help. But yeah, I agree, that's challenging.
And Dr. Matoso, in your practice, what raises the eyebrows of the clinician? Which subtype? So we know that small cell triggers of chemotherapy in most of the patients, but do you think micropapillary, plasmacytoid, sarcomatoid, which of these would sort of raise the eyebrows of clinician and make them choose a different kind of therapy setting?
Well, particularly the importance of those is that if it's an early stage, they might discuss early cystectomy. So we want to be 100% sure that the findings really represent that subtype or variant so that the patient doesn't get an early cystectomy or cystectomy at T1, and then we find out with a subsequent review that other people don't agree that that's the subtype. So I think that's a critical aspect of it. But plasmacytoid, nested, sarcomatoid, those all will at least initiate a discussion between the urologist and the patient on performing a radical cystectomy and skipping the conservative intravesical therapy.
Thank you. Over to you, Fadi.
Yeah, I have a question from the audience to Dr. Lal. Do you believe in long core 3+3, or would you call these 3+4 = 7, as most would have at least some poorly formed glands? I guess it touches on the criteria that pathologists use to diagnose poorly formed glands. What is your definition? What are your criteria? Is it the number of glands, their spatial distribution?
Yes, thank you for the question. Absolutely. It will be how you apply your definition for pattern 3. You have to be strict in the sense that you have to follow the rules about well-formed glands, well spaced out. You can see some stroma. Make sure you look at your levels. You make sure you look at the context in which the lesion is seen. And yes, there could be pretty long tumor line lengths with pattern 3, as we all have seen in our practice. But keeping your definition of pattern 4 also clear in your mind will help.
So what are the criteria you use to define a poorly formed gland?
So the poorly formed glands are the definition ranges. They could have partially aborted lumens or partially lined by the neoplastic epithelium. They are fused but start to lose their well-formed lumen, etc. So that's poorly formed glands is one of the subcategories of pattern 4 that has the most disagreement amongst pathologists, I would say, because of this a little bit more ambiguous definition.
Thank you. Rohit.
Yeah, all right. Yeah, I think another question for Priti, please. So I think one of our audience pathologists is asking Priti, what do you think is perhaps the predictive value of PNI and extraprostatic extension in prostatic biopsy? I do see you answered it live, but I think this is an important question, and I believe all audience members can learn from this question. Like, what do you feel is the predictive value or specificity for EPE as well as PNI in biopsy, and with the current multiparametric MRI option, which you had really nicely explained, do you think we can almost more depend on MRI for clinical assessment of EPE compared to what we might perceive at time of prostatic biopsy?
So we could divide the question into two as far as EPE is concerned. As I had suggested in my talk, that MRI, just like Gleason, is dependent on observers. And also the resolution of MRI is a variable. So by making the observation when you are convinced that there is fat sampling, there is actual invasion of cancer into this extraprostatic fat, by making this observation and documenting it, you may help your clinical team to either get a second read on their MRI, or even if that has not been done, get a proper workup for clinical staging, which, as you know, plays an important role in risk stratification. The second part of the question is PNI. So a single focus of PNI probably does not really affect the outcomes or management as much, but diffuse PNI has been correlated with higher probability of extraprostatic extension. So now again, the critical point to think about is all this information that we put together in a pathology report is always taken in context of the clinical scenario as well. So by reporting it, you're flagging a particular case that this has large nerve involvement, extensive nerve involvement. So the probability is higher in this particular patient of EPE.
Sounds good. Thank you, Priti. Santosh?
I think Liwei wants to make a comment. Liwei, please go ahead.
Not really comment. I want to ask a question to Dr. Lotan. It's a really quick question because you mentioned the NCCN guideline for germline testing in urothelial carcinoma. They mentioned the younger age at the presentation. Is there any did they specify the age? I know the urothelial carcinoma often in the older patients, right, 60. But younger, when they meant younger, how younger they think younger?
Yeah, this is a great question.
I was not germline.
Yeah, I was literally just talking to a colleague about that this morning. I cannot find a specific age, but someone who's more expert in the bladder cancer guidelines perhaps can correct me. I even combed through the Lynch because there's a whole kind of inherited cancer guideline which includes Lynch. That also didn't have a specific age either. I don't know if they had intentionally left it unclear, or perhaps someone else will have been able to find it. But I had the same question and I don't know. It seems a little bit vague. Yeah.
Okay.
I'll post a quick question from Ankur, who asked Tamara whether ctDNA can possibly replace a formal biopsy in patients with urothelial carcinoma. So there is some debate and topic which is coming up in recent literature of using ctDNA as a kind of a marker to look at minimal residual disease, like you said.
Yeah. As far, again, this is not my direct area of expertise in the sense that I'm not on those guidelines, but my sense is that it's more for just identifying patients at high risk of progression in terms of detectable ctDNA or non-detectable, as opposed to in addition, I guess it will identify some variants that are present there as well. But I think the emphasis is really just on presence or absence of ctDNA right now. In terms of whether it replaces the biopsy, I think we're a while off from that at this point. Although you can imagine they may, elect to do fewer biopsies in patients that have high ctDNA levels. If they see something on a scan, they would assume it's probably is metastatic.
Adi?
Yeah, question to Andres. Is MMR-HC done on all upper tract urothelial carcinoma routinely? What's the practice in your institution?
Yeah, we do it in all of the cases because it is in agreement with the clinicians, just to make sure we do not miss any particular tumor that will have MMR deficiency. It's also, it could be justified even if the guideline is not specific for upper tract, it is justified as a eligibility criteria for pembrolizumab in any solid tumor that will have MMR deficiency that could be eligible for immunotherapy. So because these tumors have high risk of invasive invasion and progression, having that information up front and not waiting until we need the immunotherapy can be helpful.
I could just emphasize on that note, like I think any tests that we can do cheaply by IHC at the time of diagnosis are super valuable just because so many patients fall through the cracks after that. So we see that in kidney right now. We can test for a lot of these heritable syndromes, or at least a high risk for them based on IHC tests. Unfortunately, we don't have that for BRCA2. That would be an amazing addition. But an IHC test can be just $100 or even less to perform. So.
And also related to the ctDNA, our clinicians are now actively using ctDNA to follow up patients under treatment for metastatic urothelial cancer and detecting a recurrence with it. So there are some tests that are being used now more routinely. In terms of prostate, Tamara knows better that, but the PARP inhibitors, if the tissue is not available, there is the option also to send it out for the mutation analysis as a ctDNA test. And some clinicians are going that pathway. It takes longer to get the result, but there is a possibility in not have to do another biopsy. I have had a couple of requests on biopsy, and then if the biopsy didn't go, it was not available, there was not enough tissue, or there is not a recent biopsy. If the biopsy is older than 2 years, then they resource to ctDNA as being more reliable.
All right. For the next question, there's a comment. Thanks everyone for the outstanding talks, which I completely agree with. And I think this question is for Liwei. Given the proliferation of molecularly defined renal tumor entities, which specific histologic clues do you use to triage cases for molecular analysis in environments where such testing is not yet standard of care?
I think that's a really good question. It's really related to the daily practice. I have to mention that there's a really overlapping morphology among these molecular defined RCC. However, there are some specific morphologic or histologic features you can use to raise the suspicious. Even you don't have a molecular to confine it, you still can use this differential diagnosis in your common. For example, the MET translocation RCC, there's like abundant voluminous cytoplasm. There's some cells with pink pale. There's a eosinophilic cytoplasm. And also the quality, even there are some clear cell, the clear cytoplasm, the quality is not really like crystal clear in a clear cell carcinoma. Still like a finely granules in the cytoplasm. That might be helpful, and also some combination of growth patterns. Sometimes most cases prominent in the papillary growth pattern and high nuclear grade. That's for the translocation. And then usually I do quite a lot of immunostain before sending for FISH. There's also like some eosinophilic or a little bit purple, pink, blue purple, like a stimpling in the cytoplasm for like a ISC or the what like ISC or the like mTOR TSC related. I think that's sometimes I understand in the practice, you don't have the access to the molecular, but with that, and at least you don't call it clear cell based on just clear cytoplasm. Then you give the differential, and then the diagnosis, the treatment kind of different. And then high grade infiltrating, you have to be cautious.
All right. Thank you. Thank you, Liwei.
Next question is for Dr. Matoso. In a radiologically, what looks like a muscle invasive bladder cancer, if the TURBT is showing in only LP invasion and some squamous differentiation in a urothelial carcinoma, would you ask for a deeper biopsy to the clinician, or would they treat it directly like a T2 lesion? And something which VIRADS looks like very clearly muscle invasive.
You're muted, Andres.
Trying to unmute, I got the screen out. So if it's already T2, we do not request additional tissue. I'm not sure I understood the question. So
the question was that whether if the radiology is very clearly, say a VIRADS 4, VIRADS 5, VIRADS 5 lesion. On MRI, if the lesion is muscle invasive, but on TURBT, it's a T1 lesion with some squamous differentiation, would your clinicians directly go ahead and treat it like a T2?
Oh, yes. Yes, that's a common situation. And I think that occasionally happens where they have image analysis, but at least they are able to discuss with the patient and explain the situation. The pathology has not confirmed muscle invasive. We have an image that is highly suspicious. We think that the best course of action will get you to do a cystectomy, but there is a chance that we're doing it early. The benefit that if it was not a T2, you're going to have a better outcome. So if the patient agrees, then it's all clear before the surgery. I think it's a matter of communication with the patient.
Yes. Adi?
Yeah, question for Tamara. How often do you see NKX31 negative prostatic adenocarcinoma, especially after ADT treatment? And if I can sneak in my question, do you actually use in your practice the Hafner classification you've shown, but poorly differentiated carcinoma, small cell, and adeno in metastatic cases?
So to answer your question first, yes, I mean, we have been using that, and we were using kind of various iterations of that previously. So we've tried to move to a more descriptive categorization in terms of, again, just giving clinicians a lot of leeway to kind of go towards the small cell type treatments or neuroendocrine treatments or adeno, AR directed treatments. NKX, obviously we use that as a prostate specific marker because it's positive in the vast majority of cases. So it usually is positive in adenos. I would say it's rare that it's very rare that we would see like an ordinary looking adeno where NKX is negative, and with the caveat that we probably don't test a lot of those unless they're metastatic. But I think the most confusing thing with NKX is we do see a lot of cases that otherwise look good for small cell. Maybe they have RB loss, but seem to have some AR signaling intact with some NKX. And I don't know how good NKX really is as like kind of a downstream AR signaling marker. I think it's a little bit more stable than that, and which is why it's such a good prostate marker. So I think we'll have to see how that bears out over time. So the most common confusing scenario we have is something that we think might be high-grade neuroendocrine, but remains NKX positive. And I think you can call it small cell in that case, but often we end up sort of just being descriptive, saying it's something in transition or not sure.
Just to add to that, Tamara, do you use the term double negative prostate cancer, which is neither showing prostatic markers nor showing neuroendocrine markers, but looks very poorly differentiated like a Gleason 5 in sheets, but doesn't show. Do you use in your practice double negative prostate? Because there is a thought process about it.
Yes, yeah, and certainly the University of Washington, the Fred Hutch group has done a lot on that. I mean, I don't usually, I guess once in a while in a comment, I might mention that this has some features of that subtype, which has been described in kind of a research setting. But we just are top lining with these either adeno, small cell, or poorly diff, or, some variant on those, yeah.
All right. I think we have room for one last question, and I think perhaps, Andres, can we request you to please share your approach on distinguishing large nested urothelial carcinomas from the inverted phenotype we might see sometimes with non-invasive papillary urothelial carcinomas?
So the question is whether some morphologic features to differentiate the two, large
Yes.
nested that
Yes.
hasn't invaded the muscle versus low grade with inverted pattern. One
Yes.
thing is that most of the nested urothelial carcinomas don't have an exophytic component. And most of the low grades that have an inverted growth have an exophytic component in addition to the inverted growth. So that's one feature. Another soft feature is that usually inverted urothelial carcinoma shows small capillaries around the nest, indicating that this is still non-invasive. This regular arrangement of capillaries around the nest is usually or more commonly not present in cases of invasive urothelial carcinoma. It's a feature that is soft, that should not be as unique, but it's another helpful feature. The other idea is the volume. If we have very large areas of very compact nests and a tumor that is very large, then it is even more suspicious. But I would say the only one that is 100% definitive is then when we find that large nest within the muscle. Another caveat could be in a patient who have had a previous TUR, and this nest of urothelium is somehow entrapped within a scar of a previous resection. So that would be a caveat in which situation we have to be more ambiguous with our diagnosis and maybe recommend a repeat TUR so we don't overcall an entrapped fragment of urothelium within a scar of a previous resection. And that's as far as my experience will go. If anyone has anything else to add, be happy to hear, but yeah.
All right. Yeah, thanks for those practical tips, Andres. Sorry, Tamara, we just have one more question we just popped up in our Q&A, and that is regarding your experience with ERG in the neuroendocrine setting.
Oh, you mean like, do we use that marker at all in the neuroendocrine setting?
Yeah. Yes.
So really largely thanks to your studies, Rohit, we have not used the IHC in that setting because, when we have a case that's AR negative, we wouldn't expect to see ERG expressed from the fusion oncogene. I guess, you could argue if you see good AR, could you then, use ERG in that setting? But I don't think it adds a lot. We do sometimes send cases to Rohit. We have in the past, like to do ERG FISH more in the setting of discriminating, a non-prostatic primary from a prostatic primary in a case that might have, neuroendocrine features. Obviously, the presence of an ERG fusion would suggest it's prostatic, but I would say rarely. So yeah, we don't. Short answer is we don't use IHC in that setting.
Yeah, thank you, Tamara. Yeah, I think what you are saying echoes our experience. We depend less on ERG IHC, and occasionally we will use ERG FISH in this scenario. So I think I think our speakers have addressed all the questions now. So I think Santosh and Fadi, if that's okay, I'll begin to close off our session. Is that fine?
Yeah.
Okay.
Yes, yeah.
So before we bid adieu, I would like to give a vote of thanks to our audience for your attention and engagement today. In case you have any ideas for topics to be covered or presentations which you would like to listen to at our future IAP GUPS meetings, hopefully, please feel free to email any of us at our GUPS Education Committee or our IAP leaders who are on board. Also, we would appreciate any feedback you might have, which will make our experience even more rewarding. I want to express my sincere appreciation to our phenomenal speakers, Dr. Priti Lal, Dr. Andres Matoso, Dr. Liwei Jia, and Dr. Tamara Lotan for their time, expertise, your amazing presentations, and thoughtful contributions to today's discussions. I would like to thank our various committees at GUPS, including our social media committee, participated by Dr. Swati Bhardwaj and Dr. Ting Zhao, and I think who have been actually live tweeting this event as we speak. Also thanks to Dr. Maggie Glutzi, who has made this event a possibility. We are very appreciative, and I've really enjoyed our such an enjoyable, seamless, and effortless collaboration working together with Dr. Zatri and Dr. Kasuf in launching this inaugural combined GUPS IAP event. So I'm requesting Christina, Ghazi, and Hala to please share some closing comments here, please. Over to you, Christina.
Thank you, Rohit. Thank you, everyone. I want to just congratulate everyone for this excellent presentation and also for sharing your valuable insight in pathology for very important and common topics. I think the lectures were very informative and was a very enjoyable session. I liked also the question that we answered with all the folks that were participating. And on behalf, of course, of all at GUPS, I would like to thank you, all our colleagues, you guys, the speakers, the moderators, the executive, the education committee for putting together such a wonderful event. And I'm very proud. I think this is hopefully the first of a long series of collaboration together with our colleagues from the other side of the ocean. And I hope that we'll do more of those educational series where people can participate. Thank you, everyone, for a wonderful session.
Again, I would like to echo what has been said by Christina and Rohit. I think this has been outstanding, very informative, instructive, and I think this has been widely received in a positive way. And I think this is an incentive for us to keep this momentum for future activities. I think this has been a very rewarding experience today. We started with an experiment, but I think it proved to be a highly successful one. And I think, I know maybe we have lost some of our audience, but I wanted their feedback. And we would like to, in order to schedule more activities, and also their assessment in which way we can make this a more fruitful collaboration. And I'd like to commend the speakers on very informative and highly instructive material they have shared with us, which reflect of their deep knowledge and expertise in this rapidly evolving topic of geopathology. And thanks for GUPS, for its leadership, for all the teams that have worked together. It has been a beautiful, wonderful collaboration over the past weeks. And I think I'm very thankful and appreciative. And with that, I turn it over for Hala to make few comments. Thank you, everybody.
Thank you, Dr. Ghazi. Thank you for all organizers. Thank you for the speakers. Thank you for every person who make this event such a success. And I would like maybe to thank an important way, maybe next time it will be like a in-person meeting that we can make together. And I would say thank you for people who have given us technology to be able to really have this meeting. Thank you from the other side of the world to all of you, and have a nice evening. Have a nice day.
Thank you, Christina, Ghazi, and Hala, for such encouraging comments and also paving the future for a possible in-person meeting. That is fantastic. Finally, last but not the least, I think Dr. Brimo and Dr. Menon, our session co-organizers and moderators, along with our GUPS Education Committee, which has been working so hard in the background, brought in so much energy, enthusiasm, and talent for this event. I think making this an enriching and enlightening experience for all of us. Thank you, Fadi and Santosh. And if you can please have your closing comments, that'd be great. Over to you, Fadi.
Thank you much. Thank you, everyone, for your participation, and for all the attendees for your interest, and the speakers for a great presentation, and to you, Rohit, for your leadership, and Christina and all the IAP members. Hope we're gonna have more sessions to come, and in person would not be a bad idea.
Would be a wonderful idea.
Yeah.
Sounds fantastic. Over to you, Santosh.
Yeah. Thank you, Dr. Mehra. Thank you, GUPS Committee, for this opportunity. Thank you for your leadership, Dr. Christina, and thank you to all the speakers. I think the session was excellent, enjoyable. It stirred up a lot of discussion. And we hope to have this going on, because GUPS is basically, the idea of GUPS is to spread the word of uropathology and keep everybody updated and abreast with what latest developments. So I think this is just the start of the events, I would say. Thank you so much, Dr. Mehra.
Thank you, Fadi and Santosh. The last housekeeping item on my agenda today is that this event has been recorded and is being recorded, and our executive committee and social media committee will be posting this in our GUPS educational videos, and generally these videos become available in about 2 days or so. So kindly visit that, and also that is a very rich resource which our GUPS members have now added a lot of lectures to. Again, thank you again to all of you who joined us today. And finally, goodbye for now, and we look forward to continuing these important conversations in future GUPS events. Thank you all. Take care.
Right, before you close, I want to express my gratitude to you as chair of the executive committee. You have done a fantastic job together with all your committee members, but we want to thank you also, because everybody thanks the other folks, but nobody thanked you. So this is very much appreciated. You have been such a wonderful chair of the education committee.
He deserves a big applause.
I want to praise you and all your
he deserves a big applause.
Thank you.
He does.
Well, thank you very much. Thanks to all of you for liking our work. And again, obviously, it is our team, which is led by Christina and our executive committee. And I think we have had just wonderful collaboration with Ghazi and Hala. And I think I thank our members of our GUPS education committee members with how many emails we have exchanged and how many times I've bothered them in the day and night. I think so. A big thanks to our entire team, and thanks to all for appreciating this session. And I sincerely hope everyone found this session to be very informative and helpful. And thank you again to all of you. And we'll be meeting again in the future soon. Thank you very much. Take care.
See you all soon. Bye-bye.
Thank you.
Thank
Bye-bye.
you.
Bye-bye.